Welcome, and thank you for joining us for our workshop on clinical trial endpoint development for locally advanced head and neck cancer. My name is Paz Valanki, and I'm a medical oncologist and currently an acting team lead on the thoracic and head and neck cancer team at the FDA. Recognizing the need to promote drug development for head and neck cancer, we have been closely working with our co-leads, Dr. Barbara Burtness and Dr. Ezra Cohen, to discuss important issues in clinical trial design and endpoint development. Our workshop today will include presentations and panel discussions from thought leaders in medical oncology, radiation oncology, and surgery, given the multidisciplinary nature of head and neck cancer. We will begin with an overview of clinical trials for locally advanced head and neck cancer. Session 2 will then be dedicated to defining event-free survival and locoregional control. Importantly, we will have a panel discussion with patient advocates and the executive directors of the Head and Neck Cancer Alliance and support for people with oral and head and neck cancer to highlight the patient perspective. Session 5 will focus on the evidence and rationale for using event-free survival as a primary endpoint, while Session 6 is dedicated to the pros and cons of locoregional control as an early endpoint. We will also begin to discuss the formal inclusion of patient-reported outcomes into clinical trial design. The workshop will conclude with prioritizing next steps for early endpoint development in head and neck cancer. Now, I would like to invite Dr. Julia Beaver, who is the Deputy Director of the Office of Oncologic Drugs and the Chief of Medical Oncology for the Oncology Center of Excellence, for additional opening remarks.
Thank you so much, Dr. Valanki, and welcome to all our participants and panelists, our truly clinical, academic, and advocate thought leaders in the field. So we're here today to really dive into a number of critical regulatory and scientific issues related to drug development for locally advanced head and neck squamous cell carcinoma. And this is, of course, important because head and neck carcinoma continues to be a serious and life-threatening disease with almost 500,000 deaths annually. Over half of patients present with locally advanced disease with poor outcomes for a large percentage of this population, still very much demonstrating an unmet medical need. There are few standard of care systemic therapy options and even fewer FDA-approved therapies for locally advanced head and neck cancers. And to date, there are not approved immunotherapy or targeted therapy options for these patients. A major part of our work in the Oncology Center of Excellence is to help speed innovations and to spur development of safe and effective drugs. Our hope with the workshop today is to stimulate discussion on drug development for this population with the hope of moving the field forward regarding much needed drug development for patients with locally advanced head and neck cancer. One of the ways to expedite and promote drug development, as Dr. Valanki mentioned, is the potential to evaluate novel endpoints to support drug approval. And we'll be focusing our discussions on endpoints and unique issues related to toxicity and symptoms. For locally advanced head and neck cancer, there are two endpoints earlier than survival, which we'll be discussing today: event-free survival and locoregional control. And these endpoints may predict long-term efficacy or may in and of themselves represent clinical benefit. And of course, a main benefit of these endpoints is that they are measured before overall survival, may not need as many patients enrolled into a clinical trial to detect a statistically significant difference compared to endpoints such as overall survival. And although overall survival is a gold standard, as it clearly represents direct clinical benefit, it presents challenges, particularly in the adjuvant setting. Since overall survival is the last event in a disease's natural history, the trial needs to be longer, include more patients, and subsequent therapies may confound interpretation, particularly when post-survival treatment is long. Across other solid tumors, FDA has accepted disease-free or event-free survival as an endpoint for drug approval, including support for indications in breast cancer, colon cancer, renal cell cancer, and lung cancer. And this is because local or metastatic recurrence after definitive therapy is a significant event and considered meaningful to patients. But with this endpoint comes challenges with definitions and harmonization, standardization, which will be critically important if we are to use event-free or locoregional control as approval endpoints. For head and neck cancer, given variability in imaging and management paradigms after completion of chemoradiation, this definition harmonization will be particularly important. And although there are large meta-analyses which have demonstrated some associations with these endpoints and overall survival, we'll also be discussing if more contemporary clinical trial data could further support the use of these endpoints, data which may take more into account the changing epidemiology and prognosis of some head and neck cancers with an increasing incidence of HPV-associated tumors, and as well as discussing improvements in definitive therapies such as minimally invasive surgical techniques. So we'll delve into these issues today with our multidisciplinary discussions with thought leaders, clinical trialists, researchers for medical oncology, radiation oncology, and surgery. And importantly, the patient voice is really built in throughout the agenda, which will include perspectives on the importance of clinical trials and discussion on patient-reported outcomes. We'll also address specific considerations for patients with head and neck cancer, given the significant morbidity and mortality of their cancers and the acute and late toxicities they endure from treatment, including a discussion of what characteristics and symptoms make head and neck cancer unique, and how can we best incorporate treatment challenges such as pain and organ dysfunction into endpoint and clinical trial evaluation. I'd like to thank our FDA organizers, Dr. Paz Vilanki, Aaron Larkins, Harpreet Singh, Gautam Mehta, and Liza Stapleford, as well as our project management support in Angela James and Christine Lincoln, and Tony Costantino and Saeed Shah for their technical support. And lastly, I want to acknowledge and thank our external co-leads for the workshop, Dr. Barbara Burtness and Dr. Ezra Cohen. They have been really closely involved with the planning and development, and we look forward to hearing their thoughts today. Ultimately, we hope to use this workshop to springboard interest and knowledge sharing for locally advanced head and neck cancer, prioritizing next steps for being able to use endpoints, in particular event-free survival, to support approval. I'm looking forward to all the conversations today, and future directions will include holding a part 2 of this workshop in 2022 to discuss other promising areas for drug development and clinical trial design for head and neck cancer. So thank you again, and I will turn it back over to the organizers.
So thank you, Dr. Beaver. We will now have Dr. Barbara Burtness provide an overview of the current landscape of clinical trials for non-metastatic head and neck squamous cell carcinoma. Dr. Burtness is a professor of medicine at the Yale School of Medicine and the director of the Head and Neck Clinical Research Program at Yale. She chairs the ECOG Akron Head and Neck Cancer Therapeutics Committee, and she is also one of the co-leads for our workshop today. So thank you, Dr. Burtness.
Thank you, Paz, for that introduction, and to you and all the team at the FDA and Dr. Beaver for putting on this meeting, which I think our field badly needs. So what I am going to do is provide a landscape analysis of clinical trials of non-metastatic head and neck cancer with a focus on a couple of issues already kind of hinted at by Paz and Dr. Beaver, the question of HPV association, sort of the slow pace of drug development in head and neck cancer and the impact that changing natural history might have on how we evaluate these trials. And so just very simply, locally advanced head and neck cancer is treated for cure. And there are two ways that we can go at this. One is that patients can have surgery, and that is followed based on the pathology findings by a risk-based postoperative treatment. And both the surgical techniques and the reconstructive techniques and our understanding of the pathology have evolved significantly in recent years. And we'll have some discussion about that through the afternoon. And then the second way that we can go about this is if the patient is not a great candidate for surgery, or if the functional consequences of surgery would be too devastating, we can substitute radiation or chemoradiation for surgery. And there as well, there have been significant advances in technique and supportive care, so that that is also not what it was when these paradigms first developed. So into a field where surgery, radiation, and the question about when do you add cisplatin had really been sort of the dominant themes for a long time, a new twist emerged in the early 2000s with the recognition that we were seeing a second new kind of head and neck cancer that was HPV associated. These were in younger patients, they had lesser comorbidities, and it turned out that their cancer not only had a different natural history, but it was much more treatment responsive. And the first prospective demonstration of this was from Carol Fackery on a one-arm trial from ECOG, the 2399, where the response to induction chemotherapy, the complete response to chemoradiation, the progression-free survival, and the overall survival were dramatically different for those cancers that were HPV associated. And then that was subsequently confirmed in a large RTOG trial where there wasn't too much difference between the two treatment arms, but if you put all the patients together and you looked at their outcome by biology, those that were HPV initiated had a far better outcome than those that were HPV negative. And so it immediately became clear that a couple of things. One is that you had to either select your patients on this basis or stratify on this basis, because you could completely confound your clinical trials results if you had imbalance in HPV association. And the second was that the overall survival for these patients was better, and the timeline that you had to follow to demonstrate a benefit from a therapy might be much longer, and this complicated clinical trial design. And then let me say a word also about HPV negative disease. You could see from those curves that I just showed you that the outcomes remain dismayingly unsatisfying for patients with HPV negative disease. And that would be an area where there would be plenty of room, one would think, for new drug development. But targeted therapy has proven to be difficult to use in head and neck cancer. You can see here the initial report from the Cancer Genome Atlas. Among the HPV-associated cancers that they studied, there were not that many mutational events, but to the extent that there were, they were clustered in PIK3CA, which is potentially targetable. But for the HPV negative cancers, the overwhelming majority had mutation in P53. This was mostly loss of function mutation. And many also had, or instead of P53 mutation, had mutation in CDKN2A. And so this loss of tumor suppressor function is much harder to target pharmacologically. So just to set what I think the broad goals are that we think of in head and neck cancer, first of all, we'd like to identify those favorable risk treatment responsive patients and think about trials of de-intensification, and I'll show you some of the rationale for that. Second of all, I've made a strong case that there are two separate diseases, different causes, different natural histories, different response to therapy. And for the one that we know to be driven by human papillomavirus, we have at present no HPV-specific therapies that are approved. In identifying targeted therapies, we're dealing with a complex mutational landscape, and at least in HPV-negative disease, this is dominated by tumor suppressor gene mutations where patient selection may need to be more creative. But the goal of overcoming these problems obviously would be to accelerate development of novel agents and strategies to improve curative therapy, both in terms of how many patients are cured and what the morbidity is that they're left with after curative therapy. One point I'd want to make is that over the course of the past couple of decades, maybe 3 now, what was going on in head and neck cancer research for a long time was just studying increasingly intense therapies. So we added 9 weeks of induction chemotherapy. We studied altered fractionation schedules, higher radiation dose, high dose cisplatin was added. And post-op therapy was more intensive as well. And in this work from Andy Trotti and others, the comparison of the toxicity over these trials shows that although there was a modest increase in the highest grade toxicity, there was a great increase in the overall toxicity burden if you looked at the number of high-grade toxicities and their duration. And then I'm also showing you very long-term follow-up from the larynx preservation trial, the 9111, which suggests that the combination of chemotherapy and radiation in patients with very high cure rates may have some long-term effects that increase non-cancer mortality. And so with increased acute, increased chronic toxicity, increased cost, the possibility of non-cancer mortality, was this intensification of therapy justified for everyone, particularly those with favorable risk HPV-associated disease? So let me show you some trial designs. We'll talk about unselected patients, favorable risk HPV-associated, and HPV negative. And I think I want to draw your attention to a few things. One is what's been the cost of not using molecular selection or not using good clinical selection criteria. Second of all, how well these patients are doing. And so where's the room for an overall survival endpoint? And lastly, how much change we're anticipating in the backbone standard of care treatment. So this is a trial from Japan Clinical Oncology Group that was presented at ASCO a year ago, looking at a very modest de-intensification question. Could you go from 3 weekly platinum to weekly platinum in the postoperative setting? It was designed as a non-inferiority study. It's not a very large study, actually, but you can see that they actually seem to show that weekly platinum was superior with a hazard ratio of 0.69. This is an enormous landmark study conducted by the NRG, a phase 3 trial to look at the question of whether or not one could substitute cetuximab for cisplatin in HPV-associated disease to try to avoid some of the toxicities, and particularly the late toxicities of cisplatin. I showed you earlier that there's a lot of PIK3CA mutation in HPV-associated disease, and one could imagine that that would lead to resistance to cetuximab. In fact, in the laboratory it does. And there was no molecular selection in this trial. Nonetheless, this confirmed, again, the utility of platinum. It did not show that cetuximab was equivalent to cisplatin and could be substituted. In fact, cetuximab looked inferior. And it showed, again, the long natural history and the great treatment responsiveness of HPV-associated disease. Dr. Suyam, who's one of our speakers today, led this NRG trial, HN02. This was a randomized phase 2 trial confined to those patients with the most favorable predicted outcomes. So these were non-smokers with non-T4 disease and non-bulky adenopathy. And they looked at 2 treatment de-intensification strategies, 60 gray of radiation with weekly cisplatin or 60 gray of radiation with accelerated fractionation and no cisplatin. The outcomes are quite good in both of these groups, although the chemo-free arm did not meet their pre-specified boundary for moving on because the lower bound of the confidence interval was below 85%. This group is now going on with a phase 2-3 trial comparing chemoradiation according to the conventional 70 gray cisplatin with 2 de-intensified approaches, 60 gray with weekly cisplatin or 60 gray with nivolumab. And then the winner of those 2 investigational arms will go up against chemoradiation in the definitive setting. In ECOG-ACRIN, we wanted to look at the postoperative management after transoral surgery for HPV-associated disease. It's been a huge acceptance of that approach. And so all the patients in this trial underwent transoral resection. And then based on the pathology, they were stratified as low risk, high risk, if they had positive margins, E&E, or a high node number, or intermediate risk. The high-risk patients got radiation, although this regimen was somewhat de-intensified with weekly cisplatin. And the intermediate risk were treated with either 60 gray or 50 gray of postoperative radiation. Bob Ferris just reported this in the JCO last week. And as you can see here, there was no decrement in progression-free survival or overall survival at 3 years for the slight radiation dose reduction that was tested here. And you can also see that the high-risk features, the E&E or high node number, do predict a somewhat worse outcome, even though those patients were treated with cisplatin chemotherapy. So I think when we think about the best use of chemoradiation, particularly in the HPV-associated setting, cure rates are high and event rates are low. And so to use overall survival as a primary endpoint in trials of that disease will mean timelines of a decade or longer, and I think really hamper the introduction of new therapies into management of that disease. And as I've been showing, clinical and pathologic risk factors can identify groups with very, very low risk. And also, I think there's enough evidence here from a number of randomized phase 2 studies in the cooperative group setting that moderate de-intensification has to be seen as feasible. And I think we can anticipate more studies looking to confirm the role of de-intensification. Okay, what about novel agents and biomarkers? And so I've been talking a lot about HPV as probably our best biomarker. Another pretty powerful one is disruptive mutation in P53 in a group of adequately resected patients, all of whom had negative margins. Disruptive P53 mutation was associated with significantly worse outcome. And we are building on this in ECOG-ACRIN with a randomized trial of radiation versus chemoradiation in the intermediate risk post-op setting with stratification based on P53. Xevinapant is a SMAC mimetic that preclinically is a potent radiosensitizer. The Gortek group, led by Jean Borges, published last year in Lancet Oncology the results of a randomized phase 2 adding this agent to definitive chemoradiation using the conventional Q3-week schedule, with a primary endpoint of locoregional control at 18 months. And so that's a endpoint that has advantages in that it reflects radiosensitization and it's short term. And they met that endpoint. So they had a improvement in locoregional control of 20% at 18 months. And many of their secondary endpoints that, maybe more global were also very impressive. So here's Xevinapant chemoradiation versus chemoradiation and placebo, 3-year locoregional control going from 56 to 78%. 3-year progression-free survival going from 36 to 72% with a hazard ratio of 0.34, and overall survival going from 51 to 66% with a hazard ratio of 0.49. And so this has led to a phase 3 design. This trial is currently ongoing, and it looks at randomizing 700 patients between platinum radiation or platinum radiation with Xevinapant, followed by about 3 months of Xevinapant maintenance to capitalize on the potential for late toxicity in cells bearing radiation DNA damage. Just want to highlight some of the other really early trials because these might move on to larger scale trials in the future. So University of North Carolina studying circulating free HPV DNA to guide management of HPV-associated disease, a study of demethylation therapy for HPV-associated disease, and then radiosensitization with a number of mitotic checkpoint inhibitors such as adavosertib or VX-970, an ATR inhibitor. Ezra Cohen, who's been my external co-chair on this project, recently reported the results of the Javelin study. This was the first first phase 3 definitive trial of the incorporation of immunotherapy with chemoradiation studying the PD-L1 inhibitor avelumab. This randomized patients to placebo and plus standard of care chemoradiation, or the same thing with avelumab with a primary endpoint of progression-free survival. And you can see here that the progression-free survival was not improved by the use of avelumab. The hazard ratio actually of 1.21 favored placebo. If you look at the forest plots and you look at the subsets, you can maybe regret that this wasn't a molecularly selected trial, because you see that the one subset that did appear to have results that favored avelumab was the group with high PD-L1 expression. And looking at overall survival, these data are certainly not mature, with median OS not reached in either group, but the hazard ratio of 1.31 again favors placebo. There's a similar trial, the Keynote 412, very similar design, anticipated, it says anticipated enrollment 780. This is fully accrued. This is a trial that randomizes placebo standard of care chemoradiation to the same thing with pembrolizumab, which is a PD-1 directed drug and maybe more validated in head and neck cancer. Primary endpoint is event-free survival. NRG is studying durvalumab, a PD-L1 drug, versus cetuximab in platinum unfit patients. This is a completely accrued study of the PD-L1 drug atezolizumab in patients who've completed definitive local therapy and get that therapy for a year compared with placebo. In ECOG-ACRIN, we're also studying the separation of immunotherapy from definitive therapy, intermediate risk HPV-associated disease, finishes chemoradiation, and then gets nivolumab or observation. And following the observation that neoadjuvant immunotherapy is quite active in head and neck cancer, the Keynote 689 trial randomizes patients to neoadjuvant immunotherapy or no adjuvant therapy, takes them to surgery, and then either incorporates or doesn't immunotherapy into the post-op adjuvant therapy, with the expectation that there will be a de-intensification of the use of platinum in those patients with a good response. So just to conclude, very broadly, the integration of immunotherapy and targeted therapy is being studied in the curative treatment of head and neck cancer, but the challenges I think that I've outlined indicate that risk stratification, the use of surrogate endpoints, and functional assessment might help us accelerate drug development in this space. So with that, I'll thank you very much.
All right. Thank you so much, Dr. Burtness, for providing this overview of current areas of clinical development in head and neck cancer. Now I will turn things over to Dr. Liza Stapleford for session 2 on defining event-free survival and local regional control as early endpoints.
Thanks, Dr. Belanki. So my name is Liza Stapleford, and I'm a radiation oncologist who works here at the FDA, and I'm excited to introduce this session. We have 2 speakers, and then we'll have a panel discussion. And I'll briefly introduce our speakers. And I just wanted to remind everyone that we do have bios that are attached in the invitation. I could probably spend a lot of time going over all the accomplishments and achievements of everyone who's speaking on the panel today, but that would take up too much time. So I'll refer you to the bios. Our first speaker today is Dr. Sue Yam, who is a radiation oncologist at the University of California, San Francisco. And she will be speaking about definitions of event-free survival and local regional recurrence for locally advanced head and neck cancer. And then after Dr. Yam, we'll be hearing from Dr. Robert Ferris, who is a head and neck surgical oncologist at the University of Pittsburgh. And Dr. Ferris will be giving a surgical perspective on designing and defining endpoints for head and neck squamous cell carcinoma trials. So Dr. Yam, if you want to go ahead and share your screen and begin.
Thank you so much, and I want to thank Dr. Burtness for that great introduction to the head and neck cancer landscape. I'm going to, let's see here. I'm going to try to follow that up with a discussion here, just setting the stage for some of the definitions and hopefully giving us some baselines to go forward into the discussion and panel later. So the drug market globally for head and neck cancer is expanding, which is kind of exciting, at an annual growth rate of over 9%. And there are many reasons for this, including an increasingly aging population, important advances in treatment and supportive therapy that are allowing longer survivals, and increasing participation by countries like China, India, and Brazil, especially with uptake of biosimilars. and the advent of immunotherapy, as Dr. Burtness just showed us. And really before, this era, there was a handful of prior approvals. I think the number was something around 6, but now there are 40 or 50 products in clinical trials across the therapeutics market. So the reason I mention this and why this is important is because at the same time, we see that the number of approvals of these compounds going through oncology clinical trials remains fairly low and is actually probably among the lowest in the oncology space. You can see here that this graph here shows you that in the oncology space, it's only 7% of approvals that make it from.
Dr. Yam, I think there's we're not getting the full view of your screen.
Oh,
and Syed, can you advise her how to?
Is that better?
Oh,
Okay.
That's it. Perfect.
Okay.
Yeah.
Yep, that's perfect. Thank you.
All right, so I'll be happy to send the slides to anyone who needs to see their full impact later. So 7% from phase 1 for oncology, which is actually lower than overall. And, only about 30 or 28% in oncology advancing from phase 2 to phase 3, which is a reminder all of us. So there's an increasing need for efficiencies in this process and consensus in these processes to facilitate the development of these drugs. And particularly with this expanding range of testing compounds, the locoregional head and neck cancer space is being affected similarly with, as you saw, quite a number of trials going on now in that space. And I thought I would just recap a little bit of history here, which I did not make up myself. This actually comes from the FDA. In the 1970s, the FDA might approve based on objective response rate, but in the 1980s determined that these drug approvals should really be based on evidence of clinical benefit. And so that meant survival or quality of life or physical functioning or improvement in symptoms, which may or may not correlate to ORR. And so for a while, large improvements in PFS or very durable ORR were used to support approval, but the FDA has been considering the magnitude of effect, relief of symptoms, and drug toxicity as well. And this really gets us into the question of patient-reported outcomes now and how that ties into PFS. ORR has also been used commonly as a surrogate endpoint to support accelerated approval. But again, the relationship of ORR to EFS, DFS, or OS still remains to be explored in some contexts. So I'm gonna just give some definitions of EFS and other associated endpoints, which we can dispute and rediscuss over the course of today. EFS is considered a time to event endpoint. So it's the time from randomization to disease progression, death from any cause, or in some cases, discontinuation of treatment for toxicity or preference or unexplained initiation of new therapy. So EFS can be used and is very sensitive for testing toxic therapies. But you can see no matter what kind of event is defined to use EFS, it depends on how you define that event. So EFS is very dependent on that exact definition. And then there are related variant endpoints like DFS, which is the time from randomization to disease recurrence or death, or progression-free survival, which is the time from randomization to disease progressing or death. And you see that these are closely related time to event endpoints. In most contexts, the FDA defines EFS as the time from randomization to progression of disease that precludes surgery. And I note that this is because of the neoadjuvant space, local or distant recurrence, or death due to any cause. And one of the interesting things that may be different in distinguishing EFS from DFS is that whereas DFS has to start when the patient is disease-free, so starts from the point after surgery or radiation when the patient has no disease and then you're looking for disease again, it may be more appropriate for the adjuvant therapy space where EFS could potentially be used for either the adjuvant or the neoadjuvant space because you can define the event. The other thing to talk about is the relationship of EFS to overall survival. So overall survival remains the gold standard endpoint because it is precisely and objectively measured and very difficult for any of us to misunderstand. But as pointed out, OFS requires large sample size and long follow-up. And it is considered to be a hard endpoint as opposed to some of these others, which you could argue are surrogates for OFS or OS. EFS, as we talked about, is the time from randomization to an event. So as you define the event, that could require a smaller sample size and shorter follow-up duration, but it may or may not predict the OS depending on how the endpoint is constructed. And there are numerous issues that are challenging with the definition of EFS, including bias in assessments, how definitions of these events may vary between protocols that are studying the same thing, determination of these events, which can often rely on imaging or an assessment schedule. And that assessment schedule has to be relatively regular, frequent, and balanced between the arms. And sensitivity to that follow-up schedule. We can talk a little bit more about the specific logistics of that and what it means when a patient is assessed outside of that follow-up schedule. And then whether independent review is required because of potential bias in these assessments. So here are some very practical examples that I came up with on my own, how there could be issues in defining events. And I say post-radiotherapy here, but this is really post-therapy in general. So for instance, when additional interventions are allowed after randomization, does that count as an event? I'll just give you an example of, for instance, nasopharynx cancer, where in some countries, if residual disease is seen, an additional boost might be given, or neck disease, where electron boost could be given for continuing residuum. Or let's say after a neoadjuvant approach, if surgery is planned after that, or whether after radiation therapy, a consolidative neck dissection is considered part of the therapy plan. These are complicated issues. Again, we can talk about the schedule and the assessments that are used and whether they're standardized. I'll just give you an example here. Another doctor may notice something on physical exam and order an imaging study outside of the prescribed follow-up schedule. And how is that considered? Or let's say that a PET-CT scan, which we usually get at 12 or 14 weeks after non-surgical definitive treatment, is ordered for a patient but is delayed or is not covered for that patient, whereas it is done for another. Or let's say that the imaging report comes back, I think we've all experienced this, and it says possible disease progression, but that is not confirmed anywhere except outside of that report. There is no biopsy and no other imaging report to corroborate that. And then the final major category of issues that I thought about was managing death as an event. In some studies, they actually tried to censor the non-cancer deaths and only count the cancer deaths as an event. And you can see how that introduces not only bias, but subjectivity. Or, the complicated issue, if you're trying to do a procedure like that, where a patient dies after a long time of being disease-free, and how you attribute that against the endpoint. So, the most conservative approach here would just be to count death as an event, death from any cause, but there are studies that do not do that. The other endpoint I think we do need to talk about today is locoregional control, because this is actually an important issue for patients. We all know that locoregional control for head and neck cancer patients can be a very important quality of life issue. And again, this is a time to event endpoint, which is time to locoregional event. We can talk more about how the definitions for that and defining an event can be complicated or variable. And locoregional control is not necessarily an endpoint that's assessed rigorously on drug trials and may not consistently reflect overall survival. So this is a study that was published in Lancet Oncology, which studied that exact issue. And what they found was that in the radiotherapy space, locoregional control and event-free survival were both correlated with overall survival. But for chemotherapy, the correlation to event-free survival was there, but not for locoregional control. And whether that's an issue of endpoint assessment or definition remains a little bit unclear, but it seems like EFS is the more all-encompassing endpoint. I thought I would just end here by talking a little bit about what we're trying to do in this space to come to more consensus. The HNSCC is the Head and Neck Cancer International Group that was established in 2014. And the goal of this group is to promote head and neck cancer clinical trials worldwide. There are over 20 or 25 member groups at present. And the Guidelines and Protocols Committee, which I have been organizing for the past year, is charged with establishing parameters for groups to work together. And what we're doing at present is surveying clinical trial endpoints in the curative and recurrent metastatic setting. We can go back to this study in the literature, which was done, led by Christophe Letourneau, who studied 40 older trials and looked at a number of endpoints in these various trials. Interesting locoregional control and overall survival accounted for 70% of the endpoints, but it was noted that they were heterogeneous. And then among the ones that were tracking locoregional failure, the term was usually not defined. And the specifications of whether neck dissection or salvage surgery or whether actual pathologic confirmed residual were counted in that endpoint was also not clear. So the conclusion of that paper was that more efforts needed to be done to standardize some of these endpoints. And the DATCAN project, which was funded originally by La Ligue contre le Cancer. You can see here, this is just an example of their methodology that they tried to apply to sarcoma, where they looked at these various endpoints and then surveyed experts in the field to figure out what should be counted as an event in those different endpoints. Unfortunately, the head and neck project, there is a working group that's there, but they have not been able to complete their work yet. And I'll just say HNCIG and DATCAN are working together with overlap between the groups at this point. And this is the HNCIG process that's going on now. We're taking a little bit different approach than DATCAN, whereas DATCAN was really looking at how a consensus survey could be used to define endpoints. HNCIG is doing a survey of the published practice-changing literature. And we're in the process now of assembling and extracting endpoints from all of the known literature since 2008, which was the advent of the EXTREME study. And after the Letourneau study, which ended in 2004. And when we have the endpoints compiled, it may be possible at that point to go to some sort of evaluative process where we select what we think have been the optimal past definitions in the literature. So kind of coming at it from two different angles. So in summary, these are some of the issues I just thought I would bring up for discussion. You know, how do we come to a consensus around schedules and assessment? You can see here that the logistics of a study are important, whether that is generalizable across contexts. How do we validate the relationships to overall survival, considering the impact of locoregional control on head and neck cancer patients, which is important, whether event definition is dependent on the specific therapy or the setting, and what is going to be our methodology to incorporate patient-reported outcomes into these endpoints. Thank you.
Thank you so much, Dr. Yam. Dr. Ferris, if you want to go ahead and share your screen.
Are you seeing it?
Yes, we can see you.
We are.
Is it with notes page or no notes page?
No notes.
Perfect.
Yeah.
It's the joys of two screens. Thank you very much to the FDA, to Drs. Burtness and Cohen for asking me to give the surgical perspective to these different endpoints. And the topic's been so beautifully introduced that I think we can focus on areas of particular surgical clinical trials, which generally becomes endpoints in the adjuvant setting or the neoadjuvant setting. My disclosures are here, and as a surgeon in Pittsburgh, we like to heal with steel. So that's our motto. Dr. Burtness introduced the evolution of this disease, and I think that has an impact on the two different etiologies of head and neck cancer, and the role of surgery in each, I think, makes the particular adjuvant trials, as I'll show examples, quite different in terms of the endpoint selected as well as not only the oncologic endpoint, but the balance of the toxicities of the treatment that we use in measuring patient function and quality of life, and I'll touch on some of those. I wanted to show this trial again, primarily because this is a recent locally advanced trial, and I thought nicely demonstrated progression-free survival, the primary endpoint above, and one can see how the curves begin to separate earlier than the overall survival curves, although neither of these curves were statistically significant. One can see about twice as quickly one was able to see things changing on the progression-free curve, which I thought was a nice demonstration side by side. Now, much of our adjuvant therapy, to think about initially the postoperative setting for head and neck cancer, for the surgically treated R0 resection, is to decide the most appropriate adjuvant therapy. And this is a meta-analysis of 2 adjuvant trials that we often use, the RTOG 9501, which had a locoregional control, locoregional failure primary endpoint, but one can see how that paralleled disease-free as well as overall survival, and permitted identification of pathologic biomarkers that predicted the benefit with the addition of chemotherapy to standard adjuvant radiation. The EORTC had a disease-free or progression-free survival endpoint, and yet we could learn similar things from the 2 trials. And these are historical trials, as you note from they were reported in the early 2000s. Dr. Yam already introduced these concepts and definitions, so I won't belabor them, simply to point out, as I think to reinforce as she did, that disease-free survival is an important endpoint when a large series of patients have a complete response or R0 resection and therefore are rendered disease-free with putative microscopic disease. Event-free survival is useful, particularly as I'll discuss in the neoadjuvant setting, since precluding a planned surgery is the definitive intended therapy in that population, as well as can integrate potential adverse events or toxicities as a novel therapy is inserted between diagnosis and surgical therapy. Just some additional points here that these have been used as surrogate endpoints to support accelerated approval, as well as the magnitude of effect. And as I pointed out, quoting the FDA back to itself, that certain committees have come to consensus that in other cancers besides head and neck cancer, disease-free survival could be considered a clinical endpoint in the adjuvant surgical setting, and I think is valid in head and neck squamous cell carcinoma as well. Now, the issue has come up with regard to locoregional control and its use as an endpoint, and in the past, this is traditionally considered important, primarily because of the anatomy of the head and neck, where major vascular structures as well as the airway are present, and so locoregional recurrence was felt to be of important patient impact. But this was prior to the ability to really operate or perform salvage surgery in a reoperative or a salvage radiated field. This has evolved in part due to advances in surgery, and as I'll discuss, microvascular reconstruction, as well as the HPV positive subset, which is a more indolent cancer type and better performance status, and therefore surgical salvage improvements have now recently expanded the extent of resection possible. And so we may want to rethink the use of locoregional control, since patient morbidity is much more acceptable with microvascular reconstruction techniques. We have new technology for reirradiation that's more targeted using stereotactic technology and hypofractionation. And as I mentioned, an HPV positive subset who experience unfortunate recurrence may be more fit and tolerate resection, and therefore locoregional control may be reconsidered as a potential endpoint under specific scenarios. Not to get too morbid, but it's important to understand what the advances of microvascular reconstruction in the ability to put fresh free tissue transfer into previously irradiated fields which provides function as well as coverage of the major vascular and airway structures, which residual or recurrent disease may potentially cause a catastrophic issue. And so this is quite an advance over the past 10 or 20 years. Just to point out with some of the vignettes for the large adjuvant ongoing trials, here is RTOG 1216, which had a disease-free survival phase 2 endpoint with 3 arms, and then a pick the winner overall survival phase 3, and this is ongoing. And also to point out that the endpoints of toxicity, quality of life, and function are progressively recognized as important, both in surgical as well as non-surgical trials, and using these, I think, with the input, as we often do on the Head and Neck Steering Committee, with patient involvement and our patient advocates to help us balance oncologic versus endpoints of toxicity and quality of life. I just want to point out an example to expand on what Dr. Burtness introduced from a large adjuvant trial just recently reported, specifically in the HPV positive subset, where based on the FDA clearance of the transoral surgical robot in 2009, a number of clinicians were using this without as much prospective data. And so we designed dual primary objectives of feasibility of upfront transoral surgery for this new subset of patients, as well as 2-year progression-free survival, comparing the oncologic outcomes of 50 gray, a reduced dose intensity, but with an eye toward toxicity and swallowing and other patient-reported outcomes. And I think this is a paradigm for the HPV positive subset. I won't go too much into the results of that particular trial, but simply to point out that as we're reducing intensity of therapy, which is a dominant paradigm for the HPV positive subset, we need to segregate out locoregional failures versus distant metastasis as we test different regimens, adding systemic therapy or not, in quantifying these because they have different impact on the patient as well as the oncologic survival as a surrogate. Now coming to the preoperative setting, the neoadjuvant window, and this can be for a therapeutic intent, as I'll demonstrate, as well as testing new therapeutic combinations from a biomarker standpoint in patient selection. Running large trials for new agents in the recurrent metastatic setting can often take multiple years, whereas the neoadjuvant window is often 4 weeks or 6 weeks and may accelerate the development in a particular disease of new therapeutic combinations. And so the endpoints traditional of disease-free survival or event-free survival may be appropriate given because they're given prior to a definitive surgical procedure. And I'll just show some examples. When cetuximab was FDA approved in 2006, and we were trying to use the neoadjuvant window to identify the responder subset, since that's a minority of patients. And we were using imaging correlates. You can see a responder on the left, as well as a non-responder on the right, but also pathologic biomarkers, which is in evolution, as I'll explain. Here's an example of PD-1 inhibitor monotherapy from a large basket trial that was reported recently. And what we saw was that overall response as an endpoint may vary whether one uses radiographic imaging, traditional RECIST responses as shown in the waterfall plot, or pathologic responses. And we were guided by a publication from Tricia Cottrell and the Hopkins group in the Annals of Oncology, I think in 2018, scoring pathologic response. And so neoadjuvant trials have some unique features that anatomic versus pathologic biomarkers may need to be selected uniquely. One can see that radiographic response on the left, whereas pathologic response is sometimes more valid as an event to score. One can see here how the different combinations can demonstrate a response endpoint versus anatomic shrinkage, and whether the typical 30% threshold is a robust endpoint. And as I pointed out, because of the many different combinations, I think the neoadjuvant window is becoming increasingly popular to help us identify subsets of patients who benefit, as well as which therapies may have enough promise to go into the recurrent metastatic setting. But we need endpoints that can demonstrate whether we are, in fact, delaying appropriate surgical therapy. We reported at ASCO that the neoadjuvant response can predict survival, both progression-free or disease-free survival, as well as overall survival. And one can see the ability to downstage a patient from the clinical staging to the pathologic staging does have a eventual therapeutic benefit in terms of survival. And so I think the endpoint in this short window of 4 to 6 weeks may have important implications for selection to move a regimen forward. Dr. Burtness introduced this sort of pre-treatment immunotherapy in the Keynote 412, and to reiterate, in a pre-operative setting, the neoadjuvant immunotherapy in this phase 3 trial, demonstrating major pathologic response using the Cottrell cutoff as less than 10% viable tumor, as well as event-free survival, which integrates the delay of surgery or the potential toxicities, I think is a paradigm that is attractive for this preoperative setting. I won't go too much into the details of that. So in summary, endpoints of surgical adjuvant trials should reflect the ability of a regimen to prevent recurrence after R0 resection, as well as the ability to test new agents and combinations, and this may occur in the preoperative setting. In an era with HPV-positive de-intensification and upfront surgical therapy now published, oncologic event or disease-free survival, as well as functional quality of life endpoints should be integrated, particularly as these are moved into the phase 3 setting. And the neoadjuvant preoperative 4 to 6 week window trials are increasing, and responses may be clinical or pathologic, but should be standardized so that we can compare the effects of these agents across different clinical trials. Thank you very much.
Thank you, Dr. Ferris and Dr. Yam, for those great presentations. So I wanted to go ahead and we can move forward with our panel discussion. And I'd like to introduce our other panel members in addition to Dr. Ferris and Dr. Yam. We have Dr. Nabil Saba, who is a medical oncologist at Emory University. We have Dr. Jared Weiss, who is a medical oncologist at the University of North Carolina. And then we have Dr. Lauren Mell, who is a medical oncologist at the University of California, San Diego. And we have about 40 minutes for this discussion, and looks like we're on time. We wanted to leave some room at the end of this to address questions from the audience. So for those in the audience, feel free to put questions for the panelists into the chat, and then we'll try to make sure that we have some time at the end to address those, or if they pertain to what we're discussing, we'll try to bring those up. There's a few issues that we wanted to kind of point out, and I think these are ones that Dr. Yam and Dr. Ferris have kind of emphasized as well, some of the most important questions. One of those is, what to do in terms of standardizing imaging protocols post-treatment. The other questions are, what's included in the definition of a local regional event, or what is included in the definition of an event? And then once you have the definition of an event determined, then how do you go about deciding where to attribute the timing of events, which is another critical issue. So lots of things to discuss, but I was hoping that we could maybe start with the topic of standardizing imaging protocols post-treatment, and I'll just open that issue up to the panelists.
Hi, Eliza. Maybe I can start first. First, I want to thank the NCI for arranging this very important event. As you saw from the talks from my very esteemed colleagues, we are sort of in a conundrum, I would say, because of the multiple events that happen to our disease, starting with the fact that it is a multidisciplinary disease to begin with. It is not really an easy disease to treat. And my concern is with all these complexities that we lose compass of what is important, what we consider important for patients, instead of being pressured with needing to get quick endpoints. So I think I would just caution, because we're in a situation where there are competing forces, if you like. We want to improve the outcome for patients, but we also should not lose the perspective of what we consider as important outcome. And I'm glad we're having this discussion. To focus more on the follow-up standard of care, I think we all realize that there is no clear standard follow-up in terms of imaging that we use, and what Dr. Ferris may be using at University of Pittsburgh may not be what we're using at Emory. And so typically what we have decided after 2 years of debates within our team is to basically follow up with a PET scan at 12 weeks, as this is being shown to have a high negative predictive value, and then follow up if the PET scan is negative with a CT scan of the neck and chest 6 months later, and continue with another 6 months and then yearly after. So maybe there are variations on the theme. I'm sure other centers may use an every 3 months scan, but this is what we do at Emory.
So I might build on that a little bit and comment that head and neck cancer is a disease state where we don't know where we stand, perhaps a little bit more than other cancers. I sometimes say to patients that good news emerges from the absence of bad news over time. And what I mean by that is very often our incured patients, people who are destined to not have an ultimate cancer recurrence event, our early signals have concerns for residual or recurrent disease. You can have heat, avidity on a PET simply from your treatment, and it can take time to go away. As well, dead cancer looks a lot like living cancer, and looks a lot like fibrosis and scarring and all the other things that my grandma would have called schmutz when we're done treating people. And so this is very hard to get an early endpoint. And in fact, in clinical care, we often revise our perspective on a patient's disease status over time. We have someone that we think it's nothing, and then we ultimately come to a state where we biopsy and prove that there is, in fact, residual cancer. There are other patients we have a high degree of concern. If we're forced to put our money down, we would say that there's probably residual disease, and then it never grows. And that makes things very hard. Obviously, you lose a lot of your ability to make an early signal if the data you're relying upon take time to become reliable.
I would add.
I agree with that.
Sorry, go ahead.
Well, I also think that as was brought up earlier, I think by Sue, I mean, not every patient has equal access to what we call standard imaging. So just the act of standardization can have the effect of skewing the population that you're testing in.
Yeah, I think that's a great point, Lauren, because just to go back to one of the things that's already been mentioned, the sensitivity of your testing procedures, can really introduce a lot of variability, right? PET CT versus CT, 10 weeks versus 14 weeks, whether the patient even gets a PET. And then, what the assessment period is. I think Nabil brought that up with Dr. Saba brought that up with the 3 months versus the 6 months. So, the sensitivity and the frequency of the assessment schedule is a big deal. And then just to highlight another thing that Dr. Saba said that really rang home for me is, what's meaningful for patients? How do we make endpoints meaningful? I love the idea of EFS because it is such a flexible endpoint. And I think it could be adapted to a lot of different settings of treatments and sequences. But I do think it's really important to remember, as Dr. Ferris highlighted, the importance of locoregional control in morbidity for these patients as well, and their experience of therapy, which goes to the patient-reported outcome. So I just wanted to kind of mention that again, because that really did ring home for me, and sort of, it's maybe it's a pie in the sky thing, but I would kind of hope that approvals would somehow be linked to what's actually meaningful for patients as well.
Can I add something, Sue, if I may? We've long suffered, and I think all the speakers highlighted this very well. We've long suffered from a disease where we don't have effective systemic therapies. And I think this is one reason why we are in a lagging behind. I mean, I'm glad Dr. Ferris mentioned breast cancer. Can you imagine if the breast oncologists are debating whether local regional control should be the way to look at? I mean, so this is, I think we're at what breast cancer was probably in the 1970s. And I think the more we have advances in systemic therapy and the more we have effective systemic therapies, the more these endpoints will change. And I think the reason we're having this discussion today very much is a result of the introduction of more effective systemic agents. And we live in a new era because of this.
I have a question for the panelists. Hi, this is Erin Larkin. I'm the Acting Associate Supervisory Director for the group that handles head and neck cancer and part of the organizing committee. What is the feasibility of incorporating standardized imaging into clinical trials is part of the issue here, and standardized management of those. PJ will get into a little bit in her talk, but if you look at the NCCN guidelines, management options, even for like an intermediate PET, are hugely variable for what's even allowed and considered standard practice. So what's the feasibility, and is it even appropriate? We've heard from some that for global trials that may be very difficult to incorporate PET universally into these. And then lastly, if we do have PET incorporated into these as part of the management, are we making the results less applicable to the actual population that's going to be treated once these drugs are approved? And is that a problem, or is that not really an issue?
I would say yes, it's feasible to standardize the imaging. We do it frequently for most of the trials that we have. Does it skew the population relative to the global population of interest? Definitely. If you're the more advanced technology you implement as standard in your protocol, the more it will skew. It's not necessarily always a bad thing, because if it's giving you specific information about the effect of the treatment, that can be generalized. And obviously, we always have to generalize our trial findings to people who are not candidates for trials. But I would say, largely what it gravitates to is what the majority of people who can accrue to trials are able to do and do regularly at their institution. Right now, PET-CT is available at most of the centers that are involved, at least in our U.S. cooperative groups, and so it doesn't seem too offensive to include that. And it has high negative predictive value when done correctly.
I noticed that we've got two people who figured out how to use the raise their hand function. So I wanted to I think Dr. Burtness was first, and then Steve Cassidy, who's one of our patients. So Dr. Burtness, if you would like to bring something up, and then we'll go to Steve after we've had a response to your question.
Yeah. So first of all, I think, the reason that the NCCN guidelines don't necessarily reflect a recommendation for surveillance imaging is that we don't actually have any data to suggest that impacts outcome. It is obviously really important for rigorous clinical trial endpoints. But I think it's just important to note that a lot of times a Medicare coverage analysis will disallow Q3 month or Q6 month imaging. So for a pharma trial where that can be supported, maybe not so complicated. For cooperative group studies, a little bit more so.
Mr. Cassidy, would you like to raise a point?
Sure, I just raise a point based on being a patient. I was diagnosed way back in 2016 and went through basic care, and then metastasis, and then a clinical trial. Just for perspective as a patient, since May 2016, I've had 18 CT scans. I've had 9 PET scans, 4 MRIs, 2 X-rays, 1 bone scan. and 55 radiation treatments. So that's, and I had my basic care all at the VA Veterans Administration. Then I was in a trial, which if need be, I can elaborate on later, at Moffitt Cancer Center. And they were different in how they did follow-up care. Neither one wrong or right, just different. And it was fine with me, but just that's my perspective. So just wanted to share that.
Thank you. I think that's a really important perspective. And as a radiation oncologist who's practiced both in academia and in private practice, I can say that, I think from, oncologists practicing in the community, having standards, standardization in clinical trials, it does eventually trickle down into practice. And that is very helpful. Particularly if the standards for imaging are set by, radiologists who have extensive experience, in neuroradiology. So I did just want to make sure we kind of touch on some of these other points. In terms of definition of events, what counts as a local regional event, particularly maybe how do we handle, neck dissections? I wonder if that's something, Dr. Ferris, you could kind of start us out talking about.
Well, sure. It's a good question to bring up, given that we went through a phase where we were predicting planned neck dissections for determination of response status. And in fact, building in a time frame where a patient could have residual disease up to 14 weeks and still be deemed a CR. If we did a planned neck dissection, that was considered part of the package of treatment, if you will. With the advent of patients on trial being heavily HPV positive, and then, some obviously most recently specific for HPV positives, that exercise of a neck dissection post-treatment, I'm focusing primarily on the non-surgical trials here, became less satisfying, in part because there is less disease that we found. But secondly, there is morbidity to it. It's a relatively low morbidity procedure, but I think does accelerate or enhance the fibrosis. And I think it's not a benign procedure to add. And so we have, primarily gotten away from doing this in a routine fashion. We certainly can do so in selected cases when there's a high suspicion for disease, but simply based on avidity of a PET scan at 3 months, which I think in many situations guided us to take a patient to the operating room, we've gotten more stringent at requesting, really cytologic evidence that there is some patient benefit to come out of it. There is data that dysphagia is worse when there's a post-treatment neck dissection. And so it's not a simple procedure as initially I think surgeons sort of felt that it might be.
So can I add to what Dr. Ferris said very elegantly here? And also going back to something Dr. Burtness mentioned initially, we need to basically ask the question, what patients are we looking at? Because lumping everyone together doesn't serve anyone. Certainly, if you're dealing with an HPV negative high-risk population where you anticipate a neck or salvage surgery, I think the traditional approach may still be feasible. I think if the salvage surgery is considered part of the plan of care, which is what we've considered traditionally, I think I can see that being the case. But when you go to an HPV positive low risk population, I agree with Dr. Ferris. I mean, doing a neck dissection may need very well to be considered an event in itself because it is morbid and it doesn't go without the patient paying a price for it. So I think what we may decide for one disease may not be the same as other diseases or subsets. But I agree completely with the assessment provided as far as the price that patients pay with the neck dissection these days, given the given the effective treatment that we have, the more effective, again, the more we are effective in systemic therapy, the more we're going to see being able to cure early stage patients and avoid these morbid surgeries. And so we have to really be careful in defining our endpoints in this low risk group. And I think for a low risk group, I would think that we should maybe consider considering a neck dissection as a negative event. I mean, Bob, you probably know how many patients on 3311 got, well, everyone got neck dissection, but that's the bad example. But I think the question is how many patients with, let's say, low risk HPV positive disease on HN005 will end up having a neck dissection.
And see what Dr. Yam has put into the chat, which I appreciate. That's a very important point. And then I noticed Dr. Lee and then Dr. Hutchinson. So Dr. Lee, if you want to go ahead and speak, please.
Yes, I actually like Bob's and Bill's perspective. I think maybe I'm just a simple person, but essentially we have a data, we're testing a new regimen against it. And if you have still persistent residual disease at 3 months when we do the PET and need the neck dissection, then that regimen's not working as well as we should be. And so to me, if and that's good data that in countries that can do PET, that the negative predictive value of PET is so high, you don't need neck dissection. That's Hisham Mehana's data. So I think if you have a PET and you still need to do a neck, that's a salvage neck, and that's regimen has failed. And to me, that's considered an event. Simple, but I'm just a simple person.
Can I ask a quick follow-up, Dr.
As long as there's disease in that specimen, because some
and obviously if it's fibrosis and stuff like that, there's also the false negativity of the PET, right, which is quite low. But I think if you have residual disease, that is a salvage. I
totally concur with that. I just said in some instances, the neck dissection, the performance of the neck dissection itself was an event. Which I don't agree with. But if there's disease in that specimen, then yes.
Yeah, and I think that's part of it's a different thing for us, I think, if neck dissection is planned up front as part of the therapy. Like anyone who has this finding after anyone who had N2 disease to start will have neck dissection, and it's applied universally across the arms. But if the neck dissection is being done differently based on response to the new therapy versus the standard therapy, and there's a difference between arms and who's getting their neck dissection, that's where we would say it probably has to be counted as an event. Because you have to factor in the potential benefit of a neck dissection. Decreasing the risk, especially if we're looking at endpoints like event-free survival where locoregional recurrence occurs. If you have the neck dissection, we assume your risk of locoregional recurrence is probably going down. Again, depending what they find there. And that's part of the problem with this definition is, do you only define it as an event if there's tumor left there? How do we standardize a pathologic evaluation? It's probably not feasible to ask for central pathologic review for all of neck dissections in these in very large trials. So this is part of what we're struggling with the definitions, I think, from a regulatory perspective.
I mean, I can tell you again that most.
Oh, sorry.
Sorry, go ahead.
Oh, Dr. Staub, I was just wanting to let Dr. Hutchinson step in since she had her hand up.
Oh, sure. I was just going to caution us against considering the neck dissection event an event based on its presumed morbidity. Yes, there are data in that space. Yes, we appreciate the fibrosis in clinic, but that's where, frankly, the secondary endpoints of the PRO should be a little bit more of a valid representation of that added morbidity. I think that we need to consider it an event if it truly is a failure of disease control and there's residual disease and whatnot, but allow the measures of morbidity to be a little bit more robust.
And I also would say, just to address your concern, I don't think that just the performance of a neck dissection in the absence of disease does much to change the downstream incidence of failure. So I think that as an indicator of the primary effectiveness of the experimental treatment, I just think that you should be looking at, did that treatment fail? And if so, you would need some pathologic evidence. And I don't think the disagreement across institutions comes down to that level, right? Like not cancer versus cancer is not an important, source of discrepancy.
Well, I mean, I do agree with you, Kate, in terms of needing PROs for sure. But, I would add also that our head and neck cancer patients get hammered so much. And I think we've gotten used as oncologists who treat this disease to basically accept that these patients will need to have, need to pay a high price to get to their cure, which may not be the case in other oncologic diseases where quality of life is really becoming of great importance. So I think to follow up on what Dr. Ferris's point is, I think any surgery, we should not take lightly having to take a patient to the operating room and dissecting the neck. I think to me, this is much better avoided than done. And given that we're seeing more and more patients with high curable early stage disease, I think we have to think about how to move it. But I agree completely with needing PROs. We need, I think that would be of great help.
We have a few panelists who've had their hands up. So we're going to, Barbara, go ahead, and then maybe Kate, and then Ezra, I think.
Okay, thank you. So I agree so much with all these perspectives, but I think that there's an additional aspect to including neck dissection as an endpoint, which has to do with the two ways in which I think it can introduce bias. One is very often when you're adding a systemic agent to chemoradiation, particularly if there's a lead-in week, you sort of know, right? And so if investigators are more worried because they think a given patient was not on the active, was not on the investigational arm, the same amount of residual disease might subconsciously drive them to a neck dissection in one case and not in another. And even if you use a definition that there have to be cancer cells there, we understand that, as you get further out from radiation, the number of viable cells will continue to go down. So doing that neck dissection earlier could, make a given arm look worse. And then the other thing is there is a relationship between bulk of disease and likelihood of having residual disease. And we do not generally balance these arms for, specific nodal subcategories. So if you had an imbalance in the number of people with N3 disease on a given arm, you might need more neck dissection there. And we haven't historically paid a lot of attention to that because we've been more focused on, longer term endpoints. So I do have a little bit of a concern that it's hard to do neck dissection as an event in a clean, unbiased way.
Only in a subcategory of patients, Barbara, the very good prognosis. But, going back to your point, exactly, we have to decide which patients are we studying? Because if you're studying, as you said, the N3, T4, absolutely, this is an expected event.
I think Dr. Cohen and then Dr. Pfister.
Great, thanks. I want to actually shift the discussion a little bit, and I don't want to be too tangential, but Lauren Mell on the panel has done a tremendous amount of work about competing events and how they influence our interpretation of the data. And I think that's worth talking about during this discussion. I don't want to sidetrack too much, but I really do think it's especially for HPV negative patients who have comorbidids. I really do think it's important to consider the interpretation of the competing events and other factors that might influence survival in any endpoint analysis that we consider. I don't know, Lauren, do you want to talk about that a little bit, or Paz, if you don't want to touch on this, I'll respect that as well.
Yeah, I mean, it's hard to talk about endpoints and not for me not to think about the impact of that. I don't know if we want to dive into it at another phase of the day, or I can certainly provide a lot of my thoughts. And
maybe that's something we could discuss during the endpoint definition.
Sure. Yeah, there's a lot of issues to consider about there. I mean, one thing that's related is just sort of when we look at an endpoint like event-free survival, the events are, so one of the kind of general conditions for composite endpoints is you'd like the components of the endpoint to be, similar in terms of their relationship to the effective treatment. And that's really where we're arguing about whether a local failure event is similar or dissimilar from a distant metastasis event. Because the effectiveness of salvage therapy changes that relationship. And then of course, a death from any cause, the or death component of our endpoint is a very different endpoint and doesn't have the same relationship to treatment. So this creates a lot of the issues, I think.
Dr. Pfister?
Yeah, very interesting discussion. There were two kind of themes that I think have kind of come up so far that, one of them has to do with ascertainment of the event. And then I think the other one is sort of this issue of consistency, that like, okay, you have to ascertain an event, but also how can you do it consistently? Okay, in the sense that, because if you ascertain with different technology or intensity, then you introduce detection bias, just that affects your outcome, but is totally not really related to your therapy. And so just a few preliminary thoughts on each of those. The first is that a couple of comments I think Jared made earlier about how you go through this period where you're not quite sure what the PET scan shows. It could be this, it could be that. And, and lots of times these events are kind of sort of early events. And I'm wondering if when we're sort of, that we should give a little bit of a ascertainment period where you're coming to grips with the fact that someone is really rendered NED or not, okay? But that may take 3 months to come to that realization. But that first PET at 3 months may look totally clean, but for many, it's still positive. And then but you're not jumping to do an ectosection. So then you kind of watch those people further. You go through this period of I'm not quite sure what's going on. We're watching the people carefully. And I wonder if we spend a lot of time trying to characterize how we're going to handle that in a reproducible way, when in terms of the downstream approval process, it may not be that important, that we basically need to get to a point where we're all pretty comfortable, this is where we are, and then start the clock ticking at that point, rather than try to overly kind of make too concrete clinical judgment early on in terms of assessment of what's going on. So, in terms of ascertainment, I wonder if there should be kind of a time point at which we would say clinically it would make sense we'd be able to make that assessment, not try to be too reproducible how we get there, but once we get there, that's where the clock starts ticking. The second thing is that in terms of this, clearly if you're defining the endpoint differently, the consistency is important so that we can do it the same, when comparing the results from different trials. And I think there's a certain tendency to do more, not less. And I would probably argue in terms of a lot of that more we're doing may not necessarily translate to such a big difference in outcome as you might think. And that really what we're looking at are outcome differences, and that maybe when we define that consistency, that we should probably define kind of core frequency that can be done in a variety of places, whether it's high resource, low resource, and so forth. Because I think some of the things which we can get seduced by technology that translate to big differences in outcome that may not be as big as we think. I think that it was, I forget who made the comment earlier about the NCCN guidelines in terms of surveillance. And this is like a theme that actually you'll see in breast cancer randomized trials, in colon cancer randomized trials. The things in surveillance that actually really make a difference are actually a pretty short list. Although people do a lot of testing in the post-treatment setting. So I think my two things has to do with, is there maybe a role for a window upon which we reach to say, yeah, this person's NED, and not get too bogged down early on, because that is a difficult thing to kind of totally structure. And then the second thing is that when we arrive at consistency, maybe arrive at a core thing rather than getting consistent in everything, which I think will be hard to execute.
I think that's an interesting. Oh, sorry. Go ahead.
I was just going to say, thank you for your thoughts on this. It sounds like you are advocating in a way for more clinical assessments of response and evidence of disease over radiographic assessments. So, just thinking about this in terms of clinical trials, it might be harder to do that consistently across clinical trials. So it'd be interesting to hear from the group how we might think about what you proposed a little bit more in the context of a clinical trial.
I mean, I can just throw out that I think that, right, you say it usually takes us 16 to 20 weeks to figure out if a person needs an neck dissection. And we are not going to count differences in outcome until people get through that period. And then, I mean, David, I don't mean to speak for you, but I so agree with what you just said.
Yeah, because I don't think, Paz, that it's a clinical only, but I think it's just a matter of, that's an assessment that's based on clinical assessments, based on, we certainly don't ignore technology, but it does take time to get to that point. And so what I'm saying is focusing on that, give a window, however people get to that point where they can really feel comfortable that they're making people felt to be NED. And up to that point, trying to characterize individual events, whether the neck dissection's event or not dissection's like the event. In the big picture, you may not really care that much, because it's sort of like it's before that window of being kind of NED.
Yeah, I mean, I think
that's it. Oh, sorry, go ahead.
Sorry, I agree with Dr. Pfister in terms of, needing to define, especially for the locally advanced group, because I think his point really applies to the, locally advanced group, post-radiation chemo, where it is expected that some patients will end up with a neck dissection. I do agree with that. And actually, when we go ahead and design these definitive trials, a lot of times the question is, where do you start randomization to a novel agent? Is it after the definitive therapy, or should you randomize before, because you need to control these these events on either arms? And I think we've struggled with that in one of our ECOG studies when we were trying to figure out how to design this study. When do we start immunotherapy? When do we randomize? Is it post definitive therapy, or is it before? And so I do agree with that assessment.
Yeah, and I think the idea of randomizing post-definitive therapy is quite acceptable. I mean, that's what was done in the Pacific study for lung cancer, right, after chemo-RT. The problem is a lot of the studies we're seeing, the drugs are being added to the concurrent chemoradiation, or even in the neoadjuvant setting and then with. So that's where the issue becomes more difficult, and where we agreed it'd be nice to have some sort of standardization of when do you start counting events and how do you time those events. If somebody has an equivocal PET and then you get another PET a few months later and it's clearly positive, was that recurrence? Should you set that back to the original PET scan? There are a lot of issues we deal with this.
I think Dr. Yam and Dr. Lee.
Yeah, I was trying to think about this like kind of more maybe systematically, like how we would address these problems. And I keep thinking about the Phoenix definition for prostate cancer, where they actually, a long time since I started the Phoenix definition, but they all got together and established criteria by which they would determine a progression event sort of post hoc. And I think that's actually, I'm just going to venture that as a consideration, because it might be something that we need to think about, both for this issue of, immediate post-treatment assessment, and also in the neoadjuvant space as well. Like, with some of these neoadjuvant studies, there's a possibility of a CR, and ideas even that surgery potentially in the as we get really increasingly effective, that some of these patients might not need surgery, and so there's going to have to be some sort of methodology, which I don't think head and neck cancer has right now, of like sort of what's that window of assessment and what are the criteria by which we go back and post hoc call an event or not. So there is I think some precedent for that in the prostate cancer community.
Yeah, so I agree with Sue. Also, the thing about it is I think that the when to call it is a universal challenge of PET across different disease sites, not just head and neck, right? So if you do a PET, and then and especially an area that's even harder to biopsy, like the lung or the GI tract. So I think that's something we probably can learn from other disease sites that sort it out. For me, the only difference between, again, I'm a simple person, the only difference between head and neck and other disease site is we can do the salvage neck dissection. And so I think that's where the issue raised up here. And I think that as per David, we are, we don't do much of anything nowadays with PET anyway for either the HPV positive HPV until we do the PET at 12 weeks or 16 weeks, right? So we can say that anything that happened before that, maybe the package of treatment, and every week we need to find a time to kind of figure out when we count as an event. After the total package, and if you define what the total package of treatment would be, that then can tell you, where the event would be. But because I think if you bring up the PET, or you bring up, you face this imaging issue, you face the same thing with other disease sites, and actually I think it's worse in lung, where a lot of radiation changes are going to be hard to tell whether this is tumor or not. So that's kind of, I think we need to kind of focus back to the neck dissection question, because I think that's where the issue that makes us different.
Thanks, Dr. Lee. Thank you all for your, good, thoughtful questions and comments. I think we did at least kind of come to a consensus about one thing, is that we think we can standardize imaging. How exactly we would do it is probably something to still be worked out, but there was a lot of good thoughts here about, sort of trying to tie together, I think, the patient perspective and what is important clinically to patients and providers to these more, I don't want to say esoteric, but kind of trial questions. And so with that, we're going to move into our next section. I'd like to introduce Dr. Gautam Mehta, and this is going to be a section where we kind of dive in more deeply into the patient perspective.
Thanks, Liza, and thanks for that nice segue into this topic. So my name is Gautam Mehta. I'm a surgeon and reviewer in the Division of Oncology 2 here at FDA. I'm excited to moderate this panel on the patient perspective in clinical trials for head and neck cancers. And this overall discussion, this workshop about endpoints in clinical trials is important because we want to find and develop products that improve patients' lives with head and neck cancers. So refocusing the discussion on the patient experience is critical, especially for these tumors which have unique considerations. Today, we're delighted to be by patient advocates Jeff Shoup and Stephen Cassidy. as well as Amanda Hollinger, who's Executive Director for the Head and Neck Cancer Alliance, as well as Marianne Caputo, who is the Executive Director for support for people with oral and head and neck cancers. So we'll keep this session informal, and I'd love for each of you to introduce yourselves and maybe give the audience a little bit of background on your story or your organization. And right now I'm not, oh yeah, there's Jeff. Maybe we'll start with you.
Okay. Can you hear me all right? All right, good.
Yes.
Jeff Shoup. I'm a 10-year survivor of stage 4 head and neck cancer. I went through the normal procedure, the 35 days of radiation, and chemo. It started out with cisplatin, but one dose, I had a very adverse reaction for my hearing, so we switched to Erbitux. And at 2-year mark, they found cancer in my lung. So I went through a clinical trial with Keytruda and completed the 2-year trial, and just found out this morning my 5-year CT scan was all clear. So we're good to go. So I understand I'm pretty much an anomaly with being 5 years out on a trial at this point, and having a complete response after about 10 months on the immunotherapy.
Thanks so much, Jeff. I think you can see by all the hand claps and comments in the chat that we were all excited to share with you news with you today. Maybe we can move on to Steve.
Greetings, everyone. My name is Steve Cassidy. So you're not so much an anomaly, Jeff, although I'm not as far out from my trial. I completed my trial in May of 2020. So I was diagnosed, as I said earlier, back in May of 2016 with stage 4 base of tongue cancer. And I went through the standard radiation and chemo care also. About 5 months after I completed that, I started having some back pain. And, about 7 months later, after final diagnosis, my base of tongue cancer, which was HPV-16 related, had metastasized to my ribs and to my liver. And so I went back in for care and got chemotherapy and radiation again. My initial chemotherapy was cisplatin for the base of tongue. For the metastatic spread, it was 6 weeks of care where I received carboplatin, fluorosil or F5FU, I'm probably pronouncing that incorrectly, and cetuximab. I got the 3 at the same time. Came out of that, did fare pretty well through that. That was, as a patient, I tell you, radiation and chemo on the ribs and lung and back and everything is nothing compared to on the throat. The throat was just flat out horrible. I was on a feeding tube for about 5 months, I think, and just, it just ravages your throat. So anything you can do to avoid that or prepare the patient for that, for what's coming, is helpful. So I completed the basic care for the metastasis, completed that, and I was stable. I didn't have a partial or full response. I was stable. It just sat there. So I spoke with my doctor at the VA about where we go from there, and she said, well, we just kind of do our 3-month scans, and at that point it was 3 months of CT scans, and we see where it happens. I said, well, what else can we do? She said, well, you can go over to Moffitt and talk to them about trials, because I think you're a candidate for some trials that they're doing over there. So I interviewed with or met with Dr. Chung at Moffitt Cancer Center here in Tampa, and entered into her trial that was the combination of cetuximab and nivolumab at the same time. I got that every 2 weeks for 2 years. I was in that treatment for 2 years and completed it in May of 2020. I had no real true adverse effects or complications or problems. It was, I would tell people it was like brushing my teeth. That's just what I did every other Monday. I went to the clinic and got treated. And I'm stable now too. I had a scan roughly 3-4 weeks ago, and I have another scan in June. I've moved from every 3 months to a 4-month, and maybe eventually 6 months CT scans at the VA. So that's my short version of the story, I guess.
Thank you so much, Steve. Moving on to our patient advocacy groups, Amanda, would you mind telling us about yourself and your organization?
Absolutely. Thank you, Steve and Jeff, for sharing your stories. I'm Amanda Hollinger. I'm Executive Director of the Head and Neck Cancer Alliance, which I've served for the past 4 years. And the Head and Neck Cancer Alliance is a patient advocacy organization that has been in existence for over 25 years. And over time, we've really grown from a focus primarily on prevention to one focused on support through the entire journey, from treatment through survivorship. And we have programs including a mentorship program, a prevention week, an ambassador program, of which Steve is one of our members. We have financial assistance for patients, educational programs, a online support community that has about 12,000 active members, and a clinical trial finder tool that we launched this year, which has had about 400 people go through and search for trials. So as everyone has discussed today, especially Steve and Jeff, those who experience oral head and neck cancer face lifelong challenges as a result of their disease and its treatment. And this often means more financial obstacles, more physical and emotional impacts. Just as we discussed earlier about how treatment is a multidisciplinary process, I think the side effects that patients experience are also multifaceted and very significant. So I'm just encouraged to be here today and hear this discussion and know that new treatments are essential.
Thank you, Amanda. And then finally, Marianne, would you mind sharing a little bit about yourself and the organization?
Sure. Thank you, Gotham, and thank you to Steve and Jeff for participating on today's very important topic for head and neck cancer patients. So Support for People for Oral and Head and Neck Cancer is a non-for-profit organization, and we're also referred to as SPUNK, which many of you have heard before. We were started by an oral cancer survivor over 30 years ago when she started the first support group here on Long Island, and now we have over 100 plus support groups throughout the country, which are vital to these patients who are, being affected by many of the side effects of treatment. We also have a volunteer program where we call our volunteers Champions of Hope. And Jeff is part of that program. And we match patients with survivors according to their diagnosis and treatment. We also offer many, many publications, and all these publications that we do offer are in layman's terms, so patients and survivors and their caregivers and their family members can understand what is being spoken about in these treatment plans and options for treatment. So there are many various resources that we offer. We've been very busy, especially during COVID. During the pandemic, because many patients have felt isolated and alone. From a patient advocacy perspective, who support this patient population, are the many quality of life issues that are very different from other tumor types. The toxicities that patients experience from treatments are heightened by the fact that functional problems and aesthetic differences are commonly associated with this type of cancer and its treatment. coping with this disease can be complex. Not only a person is dealing with a diagnosis that is life-threatening, but most also deal with possible changes in appearance, speech, smell, taste, swallowing, dry mouth, lymphedema, and many dental issues, as you all well know. So due to these side effects, many suffer psychosocial issues and look for support through SPUNK and the Head and Neck Cancer Alliance. From SPUNK's experience, as I said, our support groups and matching program have been very welcoming. And for those who are looking for others who have traveled a similar journey, the fellowship, empathy, and encouragement they receive can be very uplifting and healing. A patient, survivor, or caregiver can know that they are not alone.
Thank you, Marianne. Thank you to both of your organizations for all that you do for patients with head and neck cancers. The first question I had is for Stephen and Jeff. So one of the concepts that we really want to get out of this panel is how some of the concerns that you face as head and neck cancer survivors may be different than for other cancers. And I was hoping that you both may be able to speak to this a little. I think Stephen, you alluded to this a little bit in terms of the effects of head and neck radiation. Maybe you can go first and tell us a little bit about that.
The radiation aspects, I wonder about whether I'm getting too much radiation, and too many treatments. For example, I've seen chiropractors, and I've seen an acupuncturist and a whole health, and I do Tai Chi, all these kind of things. And, you walk into a crowd doing Tai Chi and you tell them you've had, 15 of this and 17 of that. And they're like, oh my gosh, and I remember also the acupuncturist, the same thing. I mean, they just practically have a heart attack when you tell them you've had all that radiation. I don't particularly worry about it too much. I honestly just trust my doctors. Frankly, they're the best I got. That's just my approach. My wife, she freaks out a little bit on it all, but the radiation is a concern, now I'm 4 or 5 years out from my base of care, but the neck is stiffening up, it freezes, the other side I get pins and needles, I got some back pain in my back right now, and you just suspect that, each little thing, I was like, oh, is that it again? Should I run and go get a scan? No. And where head and neck is different than other cancers, and I mentioned this during another time, was particularly as an adult male with HPV related to head and neck, there's a social stigma related to it. And actually, honestly, to be really honest with you folks in a group, it's an issue between my wife and I for our continued, frankly, sexual relationship. It's like, my wife and I are fine. We get along fine. There's no angst between us. But I'm just saying, it's in the bedroom. I'll tell you that. But we're good. Well, I'm fine. But I don't think lung cancer or maybe prostate cancer has some of that. But that's an issue. So I'll let Jeff elaborate too, if he'd like.
Thanks, Steve. There are a lot of similarities with what you said and I had. Although I lost 60 pounds over my treatment, and I went 542 days with mouth pain before it stopped, before I could actually eat without it. Having issues of thinking, oh, I got to eat, I had a feeding tube as well for about 4 months. But the neck cramps, dental problems, it all piles on to the head and neck patients. The speech too. I mean, my speech is different. How long it takes you to eat something as opposed to everyone else in the crowd. You got to chew 3-5 times more than what you normally do. So you have that, you have the swallowing aspect, the aspiration aspect, and there's other patients in our spunk group. There's probably 40 that show up in our meeting, and there's probably a third of them are laryngectomy patients. So that's unique to head and neck, which that in itself has got to be a super life-changing event, to not have a voice or really different voice. So all those things are pretty unique to the head and neck patients. I still, even 10 years out, I get neck cramps. I have limited use turning, when you're driving. So that you got to really pay attention when you drive. So there's lots of little things like that that add up. I guess, Steve, you didn't have surgery, neither did I. My surgeon, the ENT surgeon is the one that diagnosed me, and he said, if I were to do surgery, I would disfigure you so badly, so we're not going to go there. We're going to let the radiation be the knife, and I'm so thankful he did that. So anyways, that's that's the long and short of it. Lots of stories to tell, let me tell you. As what Steve was mentioning about the sex life, yeah, that's always a question, because that's how you get HPV, Now, my wife and I have been married 41 and a half years, so she's pretty healthy. She doesn't worry about it too much. And she's been tested, she has her normal checkups with her doctor. But all those little things, they're pretty specific to head and neck cancer patients and caregivers, because they got to deal with us.
So Jeff, since you mentioned the throat cancer and the weight loss, I too lost a fair amount of weight, and I didn't have any weight to lose. So they said, I asked the doctor, he said, oh, the good news is you got cancer, it's HPV related, and as cancers go, that's a pretty treatable cancer. And, so I think, you're going to be okay. And we caught it. It was stage 4, but, we caught it. He goes, that's the good news. The bad news is this summer is going to really suck. Yep. He said, it's going to really be bad. I'm like, it's a difficult treatment regimen. And I toughed it through. I'm like, I can do it, right? I'm toughing it through, and gradually the radiation builds. So as I was thinking about this while others were talking, I thought of, there's a Ernest Hemingway quote. I think it's from The Sun Also Rises, and it's, how did you go bankrupt? And it's gradually, then all of a sudden, right? So I was rejecting the feeding tube. And every time I go in, the doctors say, hey, you want to get the feeding tube? No, I can do it. And holy cow, all of a sudden, boom, I was in despair. My weight plummeted. And by the time I decided I needed a feeding tube, it was too late. I mean, I did get it. But I mean, by that time, I was really going down physically. But so that's where we're head and neck with radiation on your throat, base of tongue on your throat. That radiation is very harsh, and it's cumulative, and it builds, and that was the hardest thing in all this from a physical standpoint. What I'd like to expand on further or answer some of the other questions is related to the emotional parts.
Yeah, and I think that was something we had when we had met previously in the build up to this that you brought up, and that's something that maybe is not talked about enough with these kind of cancers. Some of these more sensitive issues, and so we're grateful to both of you for bringing them up. It does seem like some of the side effects or the effects of cancer or the treatment are lasting and they've, you're still feeling them today. So I think, there's some very unique issues here. We're going to get to, I think Dr. Pfister has his hand raised. Dr. Yamid also had a couple quick rapid fire questions that we can ask in the chat. So the first question for Steve and Jeff is, what was the burden of imaging for you? So that would be like, how much imaging did you have and how onerous was this? And then how much of, the efficacy, so getting these great clinical results, would you give up to have some of the less, a little bit less of these effects that you've described to us?
Well, the first, what was your first question again? See, that's the key thing.
You're fine. How much imaging did you have to go through? And
well, my initial treatment was 35 days, so 70 gray, and I think I counted them up. I'm at 27 CT scans. So I tell people I glow in the dark. So that was the initial. And then when I went to the clinical trial, that's where most of the CT scans came from, because it was every 8 weeks for 2 years. And then I kept fighting with the doctors and politely about stretching the scans out, because I was doing so well that I was concerned about all the radiation, over time. Because I expect to live here another 20 years, 25 years. So it's not next year, it's 20 years from now is what I'm concerned about with the radiation. So that's how much my scans were and how much the initial treatment was. The clinical trial, though, as far as the efficacy of it, like I said, I started seeing results at 7 months. I had 2 nodes in my right lung. 7 months, the one went away, and by 10 months, the second one went away. So after 10 months, I didn't have any noticeable, anything noticed in the scans. As far as the side effects, the immunotherapy treatment was a walk in the park compared to the radiation. Radiation was tough. I mean, I had a lot of mucositis. I had skin falling off my neck. There's pictures I sent. I don't know if I sent them to you or not, but there was and there's other patients that I knew that had the same 70 gray, but they didn't react the way I did. And that is interesting to me.
And Jeff, maybe I'll follow up to that, and then we'll go to Dr. Pfister for the next question. Would you be willing to give up any of that efficacy or the results you had to reduce some of those symptoms or side effects?
Well, that's an interesting question. I guess no. I mean, I wouldn't be here today talking to you if I didn't get to that trial. I firmly believe that. If I would have not gone to the trial and just had another round of radiation and chemo, I don't think I'd be here today. So I am appreciative of the trial.
Thanks, Jeff. Maybe I'll go to Dr. Pfister.
Yeah. So really appreciate both of you sharing your stories. I think that if I could maybe try to kind of follow up to the prior question, but kind of link it back to, I think, what the focus this afternoon is on, that, when Barbara kind of kicked things off, I think it was on her sides, or maybe it was Sue, I can't remember, but, one of the things that came up was, that looking at all these things in the pipeline, but then looking at the disparity with the number of approvals and how it takes a long time, and that using these surrogate endpoints is a way to facilitate approval. And it seems to me, if I'm where the FDA is and I'm looking at that sort of initial focus of the discussion, part of that is, well, from a regulatory point of view, what is going to be fair game to get that approval? And then also the presumption is from a public health point of view that getting access to these things earlier is fundamentally a good thing. Okay. Mm-hmm. And I think that, but that's kind of the perspective. Okay. Now on this panel, we're hearing what the patients have to say. And I think that the question that Sue had asked that you just said again, there is actually a history of this going back, to Barbara McNeil's original paper saying to patients who would either get a laryngectomy or radiation, would they be willing to give up a certain amount of survival? And in that paper in the New England Journal from like the early 80s, it was like 20% of people were willing to give up a certain amount in terms of overall survival. Marcy List subsequently did sort of some follow-up on that. It seemed that, maybe using a different methodology, that, it seemed that patients really were willing to accept a lot to live, okay? And that maybe that 20% was actually not really 20%. And it seems that that is a little bit of the central question as we kind of incorporate the patient sort of input into these assessment, the endpoints, is that if we just went through about how we're looking at event-free, disease-free, so forth, because in a way that's going to facilitate our assessment of these therapies and we'll be able to make decisions sooner. But if I were to go back to the patient panel now and say, gee, you heard the overall survival, event-free, disease-free, local regional control, and so forth, it kind of sounds like, well, at the end of the day, you've still got overall survival way up here, and you've got these other things kind of pretty far below it.
Right.
And are we sort of coming up with something that makes regulatory in a public health sense? And it's kind of maybe dealing with the median of the curve, but we're not really necessarily kind of paying as much attention to the tail of the curve, which is that the folks that really have these remarkable outcomes, and then they say, gee, I'm just really glad to be alive today. So I'd be curious to see, how the patient feels about that, in terms of when they look at these endpoints we're talking about, and albeit you're not the FDA, what do you think? Is it basically, well, gee, I know that looking at overall survival is a pain. Maybe we mainly just want to do overall survival and common toxicity criteria and patient-reported outcomes. That's it. And that these surrogate endpoints aren't as important.
Well, to the patient, they're not important. Yeah. To the patient. So I'm an engineer, cybersecurity, technical statistics, p-values, confidence intervals. I poured over all the statistics, survival rates, all the very definitions that you guys are saying, what does that really mean? I mean, think about how a patient looks at it. If y'all are having difficulty or narrowing down or focusing, what is the definition of this or that standard for overall survival or this and whatever, we don't know. But I'm really technical. In the end, though, I just gave it up. I was like, you know what? I'm just going to go with it. And to the efficacy of scans, stick me like a ping, radiate the heck out of me. I want to live. I had no qualms at all about where I am. I'm on bonus time. Jeff described it. This is all good. I'm living. I have in gravy. So what I'm suggesting for me, this is very much about the transactional and clinical nature of cancer care. To me, the patient, and I'm a transactional person by nature, it's not transactional. It's emotional. It's about my well-being. Jumping ahead to the other question that was going to be proposed, what did the trial do for you? And I explained to others. For me personally, it gave me hope. Things like this endpoint discussion workshop you're doing gives me more hope. And as a patient, I personally think that hope is as good a medicine as a scan and a radiation and chemo. I mean, I believe that, that hope, makes me, get better sleep, eat a healthier meal, get more exercise, all that. If you don't have that hope and you dive and you start going down, it just spirals. So, and again, this is coming from a guy who's very technical. So that's my viewpoint on it. So I think from a patient perspective, hope, the emotional, and also going to Marianne, organizations like your own that do address post-treatment mental health, stability and well care. That's been a huge factor in my, frankly, anxiety. How's that for a different side effect of the cancer? Anxiety. Got that.
Yeah. I think so. We're running a little low on time. I do want to push. I do want to continue this discussion a little bit longer and just address that. So it brings up an important point that the overall survival clearly is really important to patients, to us at FDA, and to the clinical trialists. But that also ties into this discussion about now understanding the validity of some of these early endpoints, because hopefully that will help spur early access to drugs. So these can get out earlier to patients and then be confirmed based with survival endpoints or overall survival endpoints. So there still needs to be that relationship between overall survival and some of these endpoints, which I think we're going to address in the next session. And Erin, do you have?
Yeah, I just want to make it clear that we're not really talking about looking at EFS in isolation either. So for EFS to be taken as an endpoint, it's all an overall risk-benefit assessment. So there'd have to be demonstration that there's no evidence of a detrimental effect on OS if the OS analysis is too early to be mature. And we'd look at it in relation to the toxicity profile as well. And we wouldn't necessarily encourage EFS as a sole endpoint in a study. We're talking about co-primaries of EFS and OS, or including OS as a secondary endpoint that's in the hierarchical testing strategy. So it's not anything we would look at in isolation. And I agree with Gautam. I mean, that's what some of our later discussions will be about is, if there's evidence that if we can generate evidence in the modern era, there's a good correlation between AFS and OS, it's an endpoint we can look at earlier and be comfortable or somewhat comfortable that hopefully this will translate into a benefit in OS.
So in my case, after 6 months, on a scan, they saw evidence of the tumor shrinking or going away. Is that considered an event?
But that's a little different when you're talking about, when your tumor had spread to the lung?
Yes.
Yeah, so, in some trial endpoints, we do look at response rate, which is what you experience where you actually have a response in your tumor. And that's used in many settings as an early endpoint. But we like to see that correlated with the longer term outcomes,
okay,
like when the disease is going to grow again or overall survival. So similar sort of situation where we don't usually look at that in isolation.
I might cut this discussion off a little early. I do want to get to Dr. Hutchison, who's had her hand patiently raised for a little while. And then maybe we can end with that.
Sure. I just was going to circle back. I think it was Steve, it may have been Jeff. One of you said something that really resonated, which was that there are a lot of little side effects that you've experienced that sound like they fluctuate over time, but that all add up. And as we talk about this sort of endpoint determination, one of the things that I was brought to talk about was patient-reported outcomes. And, you guys have experienced the clinical trial side of this where you get lots of questionnaires, lots of times. And I guess my question would be back at you, whether you want to be asked about all those little things individually that add up, or if you think there's sort of an aggregate type of outcome question surrounding, the impact of the side effects overall that would roll it all up.
No, I don't. No, I don't think so. I think asking, because of all the intense things that happen during the treatment, to wait to the end to ask the questions, you won't get accurate answers. I think you have to be on it all the time. And I'll give an example this way. When I was going through my initial treatment with radiation, the radiation nurses were so good. Excuse me. They encouraged me to tell them how I felt every time I went in. Mm-hmm. And with that information, they were able to preempt some things for me. So that was good. So I think the same thing would apply in your PRO, where if you are asking questions constantly, I think you'll get a more accurate response. Because I know my wife and I both, she was my caregiver. I call her NB, nurse bastard. So she's my nurse. And so we kept track of everything. And she wrote it down. She wrote the question and the answer down, because 5 weeks later, we wouldn't remember what was actually said. And that makes a difference to not just recall it, but know exactly what the doctor said or the nurse, mm-hmm. because that was very helpful. So I think those incremental questions are way better than a big lump thing at the end.
So I'm so sorry to cut this discussion off, because I know that we have a lot to cover here. But on behalf of FDA, all our workshop participants and our audience, I'd really like to sincerely thank the four of you, especially Jeff and Stephen, for sharing your very personal experiences with us. We're really honored by your participation. So we'll move on, but I know this discussion will continue offline. I did want to just quickly share the agenda, and as we move into the next session. And can you all see this? Okay, so this next session, which is at the top here, is going to review where we are now in terms of looking at how we look at some of these endpoints and validating them. And I'm pleased to introduce Dr. Ezra Cohen, who is a co-lead in planning this public workshop. Dr. Cohen is chief of the division of Hem-Onc at UCSD and co-director of the San Diego Center for Precision Immunotherapy. He's made some significant contributions to head and neck cancer research and has led multiple clinical trials in this space. He'll be speaking first on the current status of EFS and LRC for locally advanced head and neck squamous cell carcinoma. Dr. Cohen, I'll hand it over to you.
Great. Thanks, Gautam. I'll share my screen. And I know we're a little bit behind in the time, but a lot of what I'm about to say has been covered by previous speakers, so I think I can move through this very quickly. Here are my disclosures, so hopefully you believe a little bit of what I say. The endpoints in locally advanced disease, of course, the gold standard is overall survival for several reasons, and this has already come out in much of the discussion. It is the gold standard, it is easily defined, it is unbiased. Competing risks can confound survival, and that is something that we should certainly bring up for discussion. But it does take longer follow-up and a relatively larger sample size. So other endpoints have been discussed, and of course that's the basis for this meeting, and you see many of them listed here. I want to highlight this paper that was published by Dr. Mel when we were colleagues back in Chicago. And what this really illustrates are some of the competing risks for survival in patients with locally advanced head and neck cancer. And you can see that distant failure, local regional failure, are prominent. They tend to those events tend to flatten out, and then second cancers, of course, begin to rise 1 year after therapy, and looks like from this data set continue to rise even at 5 years. But the point of this, or part of the point of this, is that this is a publication from more than a decade ago. And as we've been discussing, the landscape of head and neck cancer has changed over that time, both with respect to the rising incidence of HPV and with now the utility and efficacy of immunotherapy, at least so far in recurrent metastatic disease and hopefully soon in the locally advanced setting. So with that in mind, let's talk about locoregional control for a moment. And this is not meant to really read verbatim. It's really meant to illustrate that locoregional control, and for that matter, progression-free survival, has many different factors in its definition. And again, many of these have been brought up in the discussion so far. Locoregional control is a useful endpoint for multiple reasons. It, of course, does have a bona fide benefit on its own. Patients have a impact from locoregional failure, both in terms of function and pain. Management has morbidity, and of course it impacts survival. But of course, on the other side, it can be difficult to ascertain, especially in the previously radiated neck or head and neck area. We talked about the different definitions of what constitute control. It's influenced by the frequency and type of disease assessment. It doesn't capture distant failure or death, which of course are important events, and second site of failure is rarely ascertained. Sue had spoken, I believe she mentioned this publication, so again, I'll go through this fairly quickly, but in an analysis done by Watsley and colleagues, you can see that a 10% improvement in locoregional control from this publication at 2 years was predicted to lead to a 6.7% improvement in overall survival at 5 years. But again, this is really prior to the HPV era. So with that, with that in mind, let's talk about event-free survival a little bit and disease-free survival. These definitions are from the FDA and have been discussed. So disease-free survival is from the time of randomization until disease recurrence or death from any cause. This is appropriate when a large percentage of patients achieve a CR, and of course, my apologies. And of course, this happens we expect it to happen in the context of curative intent therapy for locally advanced disease. Event-free survival, there you see the definition. I won't read it verbatim because we've discussed it, but very similar to DFS, except it takes into account the surgical management. These, of course, allow for earlier assessment and a smaller sample size, and also objective and quantitative assessment with radiographs. But assessment bias comes into play. Again, the definitions of these different endpoints, the timing of assessments, and they, of course, do include deaths from other causes. And again, getting back to the issue of competing risks. Dr. Letourneau and colleagues looked at endpoint utilization, and again, I think this publication was highlighted earlier. They looked at 40 trials, 25 actually used locoregional control as an endpoint, while 17 used disease-free survival as an endpoint. So clearly, these have been utilized before in the head and neck cancer literature. And then probably the most, let's say, definitive publication for surrogate endpoints for overall survival in locally advanced head and neck cancer came from the meta-analysis of individual patient data. This was published by Michels, but again, this was prior to the trials that were incorporated in this analysis really were prior to HPV having a larger prevalence in this disease, and certainly prior to immunotherapy. But what you can see here is that both locoregional control and event-free survival correlate fairly well with event-free survival doing a little bit better than local regional control. To look at this graphically, here is with radiation therapy alone trials. Panel A is for local regional control, and you can see panel B for event-free survival. The slope of the curve is a little bit better for event-free survival, illustrating its tighter correlation with overall survival. And the same is true with chemotherapy radiation trials. In fact, event-free survival performs even better when incorporating chemotherapy radiation than local regional control. So with that in mind, I'll just again leave you with a few thoughts and some points to discuss. That the alternative endpoints in locally advanced disease are possible. They do require standardization and standard assessment timeframes. The data would suggest that there's a good correlation with overall survival, especially for event-free survival. But let's keep in mind that the disease has changed and the treatment for the disease is changing. And so we really do need an updated analysis from the one that I just showed you. I think that would be quite useful as one of the steps going forward. So thanks, Gautam, again for allowing me to present, and I think the next is Paz to present the FDA perspective.
And thanks so much, Dr. Cohen. Thanks for keeping us on time or getting us back on time. So to discuss the FDA perspective on how we assess these endpoints, I'm pleased to reintroduce Dr. Paz Vellante, who had led off our workshop. Paz?
All right, I'm just making sure that I'm sharing the right screen. Okay, is everyone seeing the correct screen? Okay, all right. So thank you, Gautam. As Dr. Cohen pointed out, much of what I will discuss here also overlaps with what's already been discussed so far today. So however, I will try to provide a few more insights from the regulatory perspective regarding the development and use of early endpoints in clinical trials for head and neck cancer. The FDA is responsible for protecting the public health by ensuring the safety and efficacy of drugs, biologic products, and medical devices. Part of the FDA mission is also to promote innovation to make medical products more effective and safer. We organized this workshop with an ultimate goal of stimulating innovation and drug development for patients with head and neck cancer. This slide highlights the comprehensive efforts and initiatives of the Oncology Center of Excellence, or the OCE, to modernize and streamline the review and drug approval process. The OCE has a number of programs to enhance regulatory science, regulatory policy, stakeholder engagement, and education in oncology. Shown here are standard of care therapies in combination with radiotherapy for the definitive treatment of locally advanced head and neck cancer. This slide does not include induction therapies, which we acknowledge has a role in some scenarios and is used in some centers. Concurrent high-dose cisplatin with radiation is still the most greatly preferred regimen for fit patients. When considering available therapies from a regulatory perspective, this regimen is well established as the standard of care. Other standard of care therapies with concurrent radiation are carboplatin and 5-FU, carboplatin and paclitaxel, and weekly cisplatin. While radiation with concurrent cetuximab is the only FDA-approved therapy, it is generally reserved for patients who cannot tolerate concurrent chemoradiation with the other regimens shown here. Although the efficacy of these regimens is improved over radiation alone, there is also substantial toxicity with increased rates of mucositis, dysphagia, and weight loss. Here are some of the main standard of care therapies for recurrent or metastatic disease, which also has generally limited treatment options. Although cetuximab is an EGFR-directed therapy, similar to afatinib, which is another option, its use is not limited to a molecular subset of head and neck cancer, and we don't consider this a classical targeted therapy. To that end, there are no available targeted therapies for the treatment of head and neck cancer. Notably, however, survival benefit has been demonstrated with immunotherapy-based regimens, which provides a rationale for studying immunotherapy in earlier disease settings. There remain unmet needs for patients across disease settings, including for the prevention and early detection of head and neck cancer, more curative options for early stage and locally advanced disease, and to improve survival for metastatic cancer. However, as we explore novel treatment paradigms, there are unique considerations for locally advanced head and neck cancer, given the location of tumors in proximity to vital structures and the toxicity of treatment. Considerations include preventing the need for salvage resection after definitive chemoradiation or adjuvant chemoradiation after surgery, functional organ preservation, minimizing acute and late toxicities from curative therapies, and maximizing quality of life. From a regulatory standpoint, overall survival is considered the most reliable cancer endpoint and is usually preferred. However, this may require prolonged follow-up, especially in the locally advanced disease setting. However, there is potential for the use of early clinical endpoints such as event-free survival and local regional control. One clear benefit is that these endpoints can be measured sooner and may require less patients in a trial to detect a statistically significant difference. Local regional control, or LRC, is the time for randomization to first local regional event. Event-free survival, or EFS, is the time to local regional relapse, distant recurrence, or death. However, across trials, there have been heterogeneous definitions of local regional events and therefore heterogeneous definitions of LRC and EFS. Importantly, we specifically want to examine EFS and LRC as early standalone endpoints rather than as surrogate endpoints. Surrogate endpoints are really meant to refer to a marker such as a laboratory measurement, radiographic image, physical sign, or other measure that is thought to predict clinical benefit but is not itself a measure of clinical benefit. Particularly for EFS, we consider this an early endpoint rather than a surrogate endpoint, as it may be directly associated with clinical benefit. Meta-analytical approaches are important to help validate the use of early endpoints. Ideally, the early endpoint should predict long-term outcomes at both the patient level and trial level for validation. Although single-arm trial data may be used to demonstrate patient-level association and assess efficacy outcomes, meta-analyses should only include randomized trials for validation at the trial level. Trials should also be representative of the disease context. Specifically, items that should be considered are the mechanism of action of the therapy. For example, chemotherapy versus immunotherapy versus targeted therapy, characteristics of the patient population, including site of the primary tumor and HPV status, and secondary treatments such as neck management and available therapies for recurrent metastatic disease. There have been prior meta-analyses examining the correlation between early endpoints and overall survival. However, these analyses are based on data from 20 to 50 or more years ago. The meta-analysis of chemotherapy in head and neck cancer study was based on individual patient data. For concurrent chemoradiation, there were 50 randomized trials from 1965 to 2000 of almost 10,000 patients. The correlation coefficient for LRC and OS was 0.76 at the patient level and 0.72 at the trial level. The correlation coefficient for EFS and OS was 0.86 for the patient and trial level. The analysis concluded that EFS is better correlated with OS than LRC. A limitation of this analysis, however, was the heterogeneous definitions of LRC and EFS across trials. Complicating factor for establishing EFS and LRC as early clinical endpoints is the variability of assessing tumor response and neck management following completion of systemic therapy and radiation. PET-CT at least 12 weeks post-treatment is generally preferred for radiographic assessment. However, PET-CT may not always be widely available, particularly around the world, so CT or MRI of the primary site and neck are also options. If response in PET-CT is equivocal, either observation or repeat PET-CT at 3 to 6 months are recommended. For a strongly positive PET, a CT or MRI with contrast should be obtained prior to deciding between biopsy or resection of the primary tumor and or neck dissection if feasible. If CT or MRI is initially selected for radiographic assessment, observation is recommended for a negative scan, while a positive scan warrants either further evaluation with PET-CT or proceeding directly to neck dissection. Standardization of the evaluation of response and management after concurrent chemoradiation is needed within clinical trials. Factors to consider are selection of the imaging modality and availability of PET for global clinical trials, and the threshold for observation versus biopsy versus neck dissection based on follow-up imaging. Additionally, if planned neck dissection is allowed for high-volume nodal disease at diagnosis, how is this accounted for in trials? Should planned neck dissections not be considered events, but rather a part of the treatment regimen? Or should the neck dissection be considered an event if pathology is positive for residual malignancy? This may potentially be managed with stratification by end stage to ensure balance between trial arms and patients who will undergo planned neck dissection. The definition of locoregional control and events should be standardized within clinical trials. Questions to consider are, should lack of complete remission count in this event at time 0, and should this be based on clinical assessment or radiological assessment and pathologic findings? Event time must also be considered in situations of equivocal PET scans, followed by clear progression at the next assessment. There are also competing risks, such as distant metastases or deaths unrelated to cancer in a population of patients that may have significant comorbidities, which may preclude locoregional recurrence and evaluation. Contemporary meta-analyses across different types of therapies and patient populations would be helpful to assess the correlations between LRC, EFS, and OS. Standardizing definitions of EFS and LRC will involve standardizing events included in the definitions and how the time of events is calculated. EFS is considered to potentially be appropriate as a primary efficacy clinical trial endpoint for drug or biologic approval in some disease settings, although it has not yet been used to support a regular drug approval. However, LRC requires further validation as an endpoint of early clinical benefit. If LRC is validated as an early endpoint, consideration could be given to its use as a co-primary endpoint. In this context, results would need to demonstrate no detrimental effect on EFS or OS. The incorporation of formal analyses of patient-reported outcomes and randomized trials may help justify the use of LRC as a clinically meaningful endpoint. As a final remark, it's important for sponsors to request a meeting with the FDA prior to initiating a trial if they are planning to use an emerging early endpoint in its clinical development program. Otherwise, it may be problematic and difficult to interpret trial results based on early endpoints. Provided here is the link for the FDA guidance to industry on clinical trial endpoints in oncology. I'd like to thank my FDA mentors and colleagues, Dr. Burtness and Dr. Cohen, as co-leads for this workshop, and all of the speakers and panelists for the expertise and dedication. I'd also like to especially thank the patients and their loved ones for whom we must continue to strive for more effective and safer therapies.
So this next session is going to include a panel discussion focusing on EFS in particular that Dr. Cohen will moderate. And I'll hand it over to you, Dr. Cohen.
Thank you, Gautam. And it's my pleasure to moderate session 5, EFS as an endpoint in locally advanced head and neck cancer trials. The panelists for this session include some very familiar names in this field, and I want to thank them all sincerely for participating. Dr. Barbara Burtness, who you already met from Yale School of Medicine, Dr. Sue Yom, also you met from the University of California, San Francisco, Dr. Renee Mera from the University of Maryland, and Dr. Sherry Ann Nathan from Osher LSU Health Shreveport, as well as Anup Amatia from the FDA. So again, thank you to all the panelists for participating. Let's start off. I want to ask the panel what they think about event-free survival as an endpoint for locally advanced head and neck cancer. What do you think of the data? And is this a viable endpoint for us to be using going forward?
I'm happy to start, Ezra, and re-summarize your nice presentation and parts of my presentation where, based on the limited evidence we have so far, it does seem like EFS is probably more reflective of overall survival than locoregional control over a wider variety of settings. And so I think while, we recognize that locoregional control is important to patients and particularly in the radiotherapy setting, EFS is a little bit more maybe broadly applicable. And then I think I would just sort of tentatively propose that, that is a consensus that it seems like nobody has disagreed with yet this morning, that EFS is a potentially acceptable surrogate endpoint. And then the question really, I'm kind of hoping we can get to some nitty gritty here, which is, how do we define those events? And is it acceptable that the definition of events within the EFS framework would be different by therapy, by the therapy being evaluated and the setting in which it's being evaluated? That's, I don't know if the FDA wants to jump in here and answer that, but that for me is a big question.
I just want to mention one point about calling EFS a surrogate endpoint and clarify that for us at FDA, we've sort of moved away from that. Even for ORR, we don't really consider it a surrogate endpoint as much as an early clinical trial endpoint. And the difference would sort of be like for a surrogate, they've been called that for years, but really that probably should be more reserved for like a biomarker, hemoglobin A1C in relation to how that predicts how diabetes does. Because response is activity, right? So response rate is showing that there's activity of the drug on the tumor. So it's a direct effect. So we've really moved to calling those early clinical trial endpoints. So then really what it comes down to for us is which early clinical trial endpoints may be appropriate for regular approval as opposed to accelerated approval, potentially if validated well enough. Because the level of validation you need in correlation to OS is somewhat different for something where we think it would be appropriate as a regular approval endpoint on its own, where we would say, in our minds, event-free survival in and of itself could probably be considered a clinical benefit and a meaningful clinical benefit, depending on the magnitude, toxicity profile, again, in the context of the assurance that there's no evidence that there's a detriment on overall survival. So I just want to.
Yeah. So Dr. Larkins, and just to push you a little bit on that, and also drawing in on what Dr. Belenke went over a minute ago, is the consideration that EFS would be considered its own independent endpoint without the reinforcement of overall survival? Because I did notice a couple of times there was a mention that, you were interested in hierarchical testing strategies that would still have OS in there as supportive or secondary. That's why I'm a little curious about, how I guess how seriously EFS is going to emerge potentially here.
Yeah, so I still think ideally we would like that hierarchical testing, but we anticipate that you should be able to get the EFS results maybe years before you can get the OS results. So the issue with taking EFS as its own endpoint is that if someone has a large magnitude of benefit on EFS with a positive risk-benefit ratio, and even though the OS is not mature, it's pretty clear that there's at least no suggestion of a detrimental effect on OS, that could be its own endpoint. We would love to see the OS data. We do post-marketing commitments for this sort of thing all the time. We've used DFS already in multiple tumor types for adjuvant therapy. So we look at that in sort of a similar light, because especially with some of the HPV positive disease where we expect it's going to take even longer to get those overall survival endpoints, given the good prognosis. We don't want to wait 10 years to know if this drug may potentially be beneficial. So we still do encourage that ideally the studies be powered for OS when possible, if it's not outrageous, right? And that it be somewhere in the hierarchical testing.
If I could just jump in on that. I mean, I think that the reason we like EFS is that we do believe it predicts OS, right? I mean, the data seem fairly convincing for that, right? And we are, stuck with these very long trial timelines and these very long times to read out. So I think if we were consistently seeing EFS not be linked to OS, I think I would potentially say, then you got to build PROs and quality of life and functional endpoints around it, because it's not so clear to me that everything that goes into an EFS endpoint is really, worth exposure to toxicity of a drug. And I think that Sue's point that we really need to define, like some trials have second primary cancers in there, and does that make sense? And some trials have the elective neck dissection in there, and we talked about how that could be biased before. But I think that the reason people are so interested in seeing EFS be accepted is that it does look like it's a pretty good, I won't call it surrogate then, but partner, friend to OS. And
early. I think they like the word earlier.
That's
earlier.
Early readout. And they're clearly active drugs that are not making it into patients in this disease, right? So I'm sorry, Ronnie.
And part of the issue is we talked about that we need to look at some updated meta-analyses, and we're not going to get some of this for a while, unfortunately, as we don't know how this will emerge with the IOs, because as you all know, in a lot of these disease settings, especially outside of first line, they actually don't show great PFS differences, right? So I don't know what we'll see with EFS. I'm hoping that's not the case, and that maybe it will still be correlated, but it doesn't always seem to correlate for some of the IO therapies.
Well, I would argue that with the increasing use of IOs in the metastatic setting, that gives us more value for EFS in evaluating an endpoint for a locally advanced trial. Because, we heard two wonderful survivor stories that both of them did have an event, right, from their locally advanced treatment, but they're still doing well. And if survival was used to follow them, we wouldn't be appreciating all that they've gone through with regards to their recurrence. And they're both doing well because of their IO therapy. So it's the EFS that gives us that signal on the value or the efficacy of whatever the locally advanced paradigm that's being studied is.
And I think that's a great point.
Lauren, I do see your hand up, and we'll get to it. So keep it up. I'll say if anybody else, please feel free to raise your hand or put in questions in the chat box. Sorry, Aaron, didn't mean to interrupt you. Go ahead.
Oh no, I was just going to say that Rainey's point is a great point, and I think that's sort of where part of what hadn't maybe moved a lot of the local regional development in head and neck cancer was that there was not a lot available after. So OS was still a completely reasonable endpoint for these local regional control trials, because afterward you're going on, chemo with Tux was like the first advance we had for a long time. And even that obviously is not fabulous. So with some options coming into those later lines where, again, now survival is being pushed out further, that in combination with HPV positive better prognosis makes it more important, we think, to try to bring EFS forward, even with all the complications that come with it.
Aaron, I would add that there would also be value to having avoided, let's say, the IO that would be utilized for patients who have an event that is not mortal. That is to say, if EFS is the primary endpoint and you avoid the therapies for recurrent or metastatic disease, I think that would be viewed as a benefit to an intervention. So there's two sides to that, two levels to that argument. Aaron and Sherry Ann, did you want to comment before we go to questions? I'll provide you. What do you think about EFS and the data so far, and what are your thoughts?
Go ahead.
Yeah, sure.
Arun, did you want to? Oh, sorry, Anoop. Sorry, my apologies.
Yeah.
Did you want to comment?
Yeah, just on the data, because the meta-analysis was quite early on, and that's probably one reason why we're seeing such a high correlation between EFS and OS, because of the lack of effective therapy in a later line, etc. As we go forward and we see more and more effective therapy, that level of correlation may not exist. And that's not because of the lesser efficacy of a drug, it's just because of what's available. So that's something to keep in mind when we try to keep on correlating EFS with OS and thinking, and that needs to factor in when you think of EFS as, do we consider it as the early endpoint or a surrogate? That has a little different meaning to it.
Thanks. Sherry Ann, did you want to make a comment?
Yeah, no, I was just going to say, I agree, event-free survival was much better early clinical endpoint. I was just interested in a comment made by an earlier speaker about event-free survival not being great for an adjuvant trial compared to DFS, but it looks like in a lot of other organ systems, event-free survival has been used. And I was interested in, why it wouldn't be good for adjuvant trials in head and neck, if there was any.
Yeah, I think that's what I was thinking about too, Sherry, just the need to define the events across different settings, right? I think we've heard a lot now about, adjuvant, neoadjuvant, post-radiotherapy, and then now people are bringing up immunotherapy where you can have inflammation and weird things. And I personally had a lot of patients on immunotherapy who their disease was clearly getting worse radiographically, but they felt okay and they lived a long time. So it just, I think again, trying to just think about a way to go forward here. And again, this is what we've encountered in the HNCIG is just every setting, the nuance of what an event is really different. And so in the surgery setting, since the disease is potentially removed, you're looking for relapse, right? Which is very different than post-radiotherapy where you're looking for progression, et cetera, et cetera. Anyway, I'm sorry. I know Lauren's waiting here. I'm going to be quiet now.
Yeah, Lauren, go ahead.
Well, the first thing I was going to say is if the rationale is not to actually use a surrogate endpoint the way it's been used in other studies, but to use an early trial endpoint, then you don't need the or death component in the endpoint, and that's not specific to the effective therapy. So it would actually improve your model to remove that event. It gets you away from the customary clinical meaning that we attach to EFS, but if that's the goal, is not necessarily to use a surrogate endpoint, then you don't need that component of the end.
I would say that's, to us, we would consider it a surrogate more if you're only looking at the effect it has on tumor, trying to predict something. The death event has to be in there for, I would say,
it doesn't have to be in there for response, and so it really amounts to
response is an accelerated approval endpoint. So it's an early, again, it sort of depends what the early clinical trial endpoint is being used for. There are some which we consider maybe will support accelerated approval, but we're going to need confirmation or verification of clinical benefit based on longer term time to event endpoints. This is a time to event endpoint. If you're already
going to insist on it from looking at the survival data, then that it's not really contributing much, I would argue.
Unless you had a signal of toxicity related death, right?
When that's sort of why we have the death. That's why the death is in there.
Survival endpoint, which you're looking at anyway. So from an endpoint definition, right? Because what happens is it introduces a non-specific endpoint into your design, which has implications for power and sample size. You're powering the study now to overcome the nuisance event in the background. So if your goal is to develop a proxy endpoint, right, that it's going to give you an earlier readout that still is conditional later on further information, right?
But it's not conditional. That's what we're trying to say. So this would not necessarily be the same as a conditional approval.
But it is, because you're looking at the survival data. Not necessarily be the case that someone
would have to win on OS, if I can sort of make that clear, as opposed to no detriment. So it's a maturity issue. So I'll tell you from a regulatory perspective, because we're looking at the overall risk-benefit assessment, death will be included in that EFS.
Let's just say your cancer event rate were lower with the experimental therapy and survival was not different, regardless of looking at EFS. So what would prevent you from approving that therapy?
Well, if survival's not different, then what's the, like,
no, that's what we're talking about. EFS is giving you the green light. Survival is not worse. So that's all that's required from the survival.
But you could imagine, I mean, just because of your background with coexisting morbidity, right? But you could imagine a group of patients who had only a 9-month median life expectation independent of their cancer, and then you give them this thing and they all have a great response, but they all die at 9 months anyway. I mean, it's obviously an absurd example, but the point being, if it's not going to improve survival, and then you want to say, well, the event-free survival is better, don't you have to have your pain is better or your swallowing is better? Don't you have to have some functional evidence that not having an event was really beneficial if it did not lead to improved overall survival? I mean, I have to say, the reason I'm so supportive of EFS is I believe it will predict.
Right, because the prior data says it's a good proxy endpoint for survival. That's what we're comfortable with that notion. But but so separating the surrogacy, it doesn't make sense from my perspective. It'd be the same. It amounts to the same question as a response. Then, if you're going to grant a conditional, or you're going to grant approval on the basis of response, response has that same property.
But again, so response would at most support an accelerated approval, which would require further verification of clinical benefit.
But it sounds
we're
like
talking about trying to use EFS for potentially regular approval.
I was trying to, I was interested in what Dr. Burns said, because, it makes sense to me. If you're seeing a discordance or, a lack of correlation between EFS and OS, then it could be due to subsequent therapy, absence or presence. It could be due to other factors, but in that case, I think the point she made was that you would need additional support. You would need benefit to the patient of some other kind, either, quality of life or symptoms or something like that. And I believe that is what the FDA has required in the past in those situations, right? If the overall survival is in question, then the event-free survival should be additionally supported with other forms of benefit. Is that accurate?
I mean, we look at all the endpoints tested. So generally look at response. Unfortunately, PRO collection is usually not rigorous enough or pre-specified enough in these studies for us to use it as anything other than maybe vaguely supportive, which is why you don't see a lot of this included in labeling, but we would be fully behind people trying to incorporate those more into these studies as additional supportive evidence for the value of EFS as its own endpoint.
Hey, Nabil, you've had your hand up for a little while. Go ahead. Please remember to take your hand down after you've had an opportunity. Thanks, Nabil. Go ahead.
Thank you, Ezra. Thank you. It's fascinating discussion. And I think I want to go with what Barbara basically, and agree with her on, and agree actually with Dr. Larkins too, because I think, the needle is moving, quite fast on immunotherapy. And even if you look now at recurrent metastatic trials, I mean, a trial like 651, where you would have thought would be a positive trial, and you look at the overall survival of these patients, that is really amazing. But then it couldn't reach it because the standard arm patients were able to take immunotherapy. And so we have to be cognizant of this. And I think, as Dr. Larkins mentioned, the event-free survival should be used, and I agree with needing to use it, but should not be used to declare the final, victory, unless there is basically a very negative signal that you're seeing early on. because ultimately the longer and longer patients are living, the more delayed the final answer may become to reach that overall survival difference. So I think as long as the event-free survival is actually heading in the right direction, it would make sense to, let's say, move on with an early approval, provided this is confirmed at the end with overall survival, if that makes sense. I mean, I don't think
it does.
I don't think just relying on event-free survival is going to be enough for many of these trials.
Yeah, I mean, and
I don't know.
You know, that's the point we're trying to get at is can we rely on EFS as the endpoint for approval?
To a certain degree, what I'm saying, Ezra, is yes, if, provided, so you can rely on it if it provides you a negative signal, but you cannot rely on it if everything looks okay and you still need to wait for the OS signal. I think that's not the end of the story if you don't get a signal.
Yeah, so you would, what I'm hearing you say is if EFS was positive, you would still want to wait for OS? Is that what you're saying, Nabil?
If EFS is positive, I think I would be much more likely to essentially accept that this is a standard.
Oh, so you are. Okay, all right. Sorry, I did
But if EFS is not positive and has not really produced a positive result, then I cannot really conclude.
Sure.
That's what.
Sure.
Of course.
It did sound a little as if you were maybe arguing for EFS as more of an accelerated approval with ultimate need for verification that OS is improved.
Yes.
So that would be one potential approach. But the question there comes in is, what if there is no difference in OS because we now have all these different standard therapies?
That's a very good point.
If you have a better EFS and you can prevent someone from having to go on a new therapy for 3 years, is that worthwhile in a clinical benefit in and of itself? And I think that would be where we're wondering, do people think there's an argument for EFS as its own standalone, valid, clinically meaningful endpoint?
That's exactly the question.
With no detriment
thanks,
to
Nabil.
OS. Right, with no clear detriment to OS, I think.
Yeah, exactly. So, sorry, Sergio, I see your first name. I don't see the last name. So, Sergio, I'll let you go ahead.
Thank you, Ezra. I'm Sergio Schildergemein, but Sergio is okay. So I'm very glad of hearing all this discussion. I think it's very positive to see all these comments and angles of view. I think also the main spirit behind this discussion on endpoints is, rather than if EFS is an acceptable endpoint in clinical trials in patients with curative intent, is whether we should define situations where another endpoint, which are not those traditional like EFS, disease-free survival, may be relevant or important, and maybe not in conjunction with the patient-reported outcomes, but for example, in trials that are exploring radiation alone, or in a specific population like age patients, where typically the reasons for death, for example, are varied, and maybe in order to adequately power a trial to show an overall survival benefit, we will need to treat thousands and thousands of patients without clearly seeing the effect of the treatment.
So yeah, it's a good point, Sergio. So it should be context specific. EFS may be a great early endpoint in some situations, but may not serve us well across the board, if I'm interpreting it correctly. Quinn, you've got your hand up next.
Yeah, I just want to go back to Rane's comment. I think that where we see the difference, the question is when does EFF not track with OS, especially when we track survival as part of the EFS endpoint? And I think the issue is either a salvage treatment or a late toxicity or that we were not tracking for years, or something that Barbara mentioned, that the patient is had a short life expectancy anyway. But I think that scenario we also survival is part of EFS, right? So the main question is the delay between the EFS and the OS. And so I think, with now in the past, without any salvage treatment, effective treatment, it was my concern is now we may not see a difference in OS, but we have so much good salvage treatment, the control arm's going to have it. And if we focus on OS, we may not see a difference because of the salvage therapy, the effective that we have now. And so that's why I want to kind of bring it up. I'm supportive of EFS because of the effective therapy that we have now.
Thanks, Quinn. Barbara, do you want to? You got your hand up.
Yeah, this is such a rich discussion, and I really like Quinn's points. I guess as I think about, if we're saying, well, EFS is a benefit because they don't have to go on therapy for 2 or 3 years. I think that's the example that Erin gave. It did remind me that some of these trials that we're doing now involve a year of immunotherapy to prevent that event, right? And so if you're doing it in T4 HPV negative, high pol beta, completely platinum resistant, maybe that's a great trade-off. And if you're doing it in intermediate risk HPV positive, I mean, maybe one question is like sort of what's the area under the curve for the total of months of therapy that patients are on? And obviously some of these salvage interventions are SBRT to a solitary lung lesion 5 years out from chemo-RT in an HPV positive patient who will then do well for another couple of years, right? So I totally take this point, but I think the salvages are not all the same. And if it's a little bit like, do you take 5 or 10 years of tamoxifen as breast cancer prevention to avoid taking 5 or 10 years of hormone therapy as adjuvant therapy when you know that 50 times more people are going to get tamoxifen with strategy A, right? So maybe we do need some way of understanding what's the total amount of contact with the healthcare system on the 2 different arms. And I know some of these trials have, cost analyses built into them. Maybe that's one way to get at that.
It's a good point, Barbara, and I see some more hands up, but we're about 60 seconds from the end of this session. I would like to at least get some opinions on what data are needed, following up on Barbara's comment from the panel. Really quickly, if the panelists could make a comment on what would you like to see, what data do we need to collect? Sue, do you want to, or if you're still available?
Oh, I was typing. I was typing into. Sorry. Anyway, well, I was typing into the chat. I think I do think that there is just a logistical component to this, which is that following for OS for many years. I mean, I think we have to really consider how valid that data becomes after a few years or several years, and also the administrative and financial burden of imposing that on the clinical trial system. So I do think the earlier readout concept is really important on a number of reasons, just burden to patients, ourselves, the healthcare system. And then the other thing is that, it does seem like some of the information we need here is, what constitutes the definition of event. We've been talking about that all morning. Right. And I would propose, and, I'm certainly not an expert on this stuff, although I'm learning very fast today, but, it seems like the events from my perspective seem really different across different settings and potentially across different populations too. And so defining those events and defining intervals of assessment, and then the other issue potentially being how we, how do we call those events? I think we talked a little bit about like sort of windows of surveillance and what the schedule of assessments is, because, I can imagine in drug trials where the differences
some standardization.
Time can be very short, right? A 2-month difference.
I want to give every panelist a quick chance to. Anoop, what other data information do we need here?
Yeah, I am a statistician, and I look at the trial data, and whenever we have this uncertainty in the definition, how the events are timed. We always like to see more granular data, so we can do several sensitivity analysis just to make sure that the results are robust for slight variation in definitions that are used. So I think having those granular data will help to build confidence in this endpoint, at least early in this phase.
Thanks. Ronnie, what?
Yes, thanks. So I think one thing that we're lacking is the historical context to use to help benchmark our EFS endpoints. I mean, we all can look at trials and past data and pull the PFS data and the overall survival data and use that in context to develop another prospective study. But if we're still in the process of defining EFS, it's very difficult to go back into the prior literature we have and gather historical data for us to discuss with our statisticians. So that I think is the limitation that we have right now, even though we all agree that it's a valuable endpoint to consider. And so while we're still gaining that historical perspective, we may still need to use some sort of more clear survival endpoint in conjunction with the EFS. The other thing that I think is important to follow is whether the event is more of a toxicity endpoint versus a recurrence endpoint, because that will provide us some context also in how to interpret the data.
Thanks, Ronnie. Sherry Ann, do you want to comment? Take yourself off mute. Take yourself off mute.
Oh, sorry. Not a whole lot more to add. I agree with Sue. I think if we use overall survival still, then that's kind of defeating the purpose. And to me, I think PROs, even though it's hard to define, is still an important point for when we consider event-free survival.
PROs, yeah. And Barbara, I'll give you the last word.
Yeah, no, just great discussion. I really agree with a lot of these points. I think the possibility that IO in the salvage setting is going to change the balance of what we think about the EFS-OS relationship is something I hope we can be really nimble about establishing in the trials that are ongoing, and that it's not going to take us 10, 15 years to get the meta-analysis done to answer that question. I think understanding what's an important salvage event, what's an important event are going to be key.
Yeah, all great points, and I want to thank the panelists. Sorry, I know Lauren, David, you have your hand up, but we are out of time for this session. My guess is that some of your comments may apply to the next session, and so with that in mind, I will turn it over to Barbara, who is moderating the session 6. Thanks everybody for participating in session 5. This was a great discussion.
Okay, thank you, Ezra, and thank you to all the people who are participating in this section. So this is locoregional control as an endpoint in locally advanced head and neck squamous cell cancer clinical trials. And we're going to start with an evaluation of the pros and cons of using locoregional control to evaluate this, delivered by Zen Hussain, who's an associate professor of radiation oncology at the University of Toronto and an accomplished outcomes researcher who has thought about these kinds of questions quite a lot. And so we'll use that to kick off then a panel discussion around locoregional control. So Zen?
Yeah, thanks, Barbara, for that introduction. You guys see my screen?
But it's not in slide.
Let's do it.
Great.
Okay, so thanks for inviting me to speak. We're talking about local regional control, no disclosures. So I think it's important, we'll use a sort of a very practical definition of local regional control here. It's just control of disease at the primary site or within the neck. I think we've heard about some of the details about what do we do with salvage necks and things like that. I think those are probably best served in the more discussion section. But I did want to go over the fact that local regional control has actually been used as an endpoint in a lot of the seminal trials in our field. So RTOG 9111, which is probably the most relevant for how we treat patients today, used a modified local control endpoint of larynx preservation. RTOG 9501, which established high-risk cis-RT for the high-risk post-op patients. The Bonner study with cetuximab was also local regional control. And then you had a gap, and now there's been a couple of more studies using this as an endpoint. So it's become certainly less popular over time, but the weekly cis versus high-dose cis used it. And then maybe most relevant for this discussion, since it's the first novel agent that's shown benefit in combination with cisplatin in a randomized setting, the W1143 study, which looked at local regional control 18 months, but that was a randomized phase 2. So, we were really lucky to have Steve and Jeff on and to talk about what matters to patients, because I think that's what this is all about ultimately. And so this is some work that comes from Carol Thackeray's group, where they ask patients, what is it that matters? And it's very consistent. So they interviewed 150 patients prior to treatment and they asked them what's most important, and it was cure, survival, and swallow in that order. And then they had a separate group of about 30 patients where they asked them before and after treatment what matters to them, and they would rank it. And again, it was cure, survival, and swallow. The only difference after treatment was really the fact that moist mouth, so these patients are now feeling the effects of xerostomia, and the prioritization of moist mouth went up a bit. So talking about, I think it's important to understand the way these patients fail as we understand the difference between local regional control and event-free survival. And so patients, whether they're HPV positive or HPV negative, and this is from the from RTOG 0129, they tend to fail local regionally. So in the HPV negative cohort, 35% of patients failed local regionally. That was the most common mechanism of failure. In the HPV positive group, it was about 14%, and this difference is statistically significant. For distant Mets, the rates were somewhere between 10 and 15%, and not really statistically significantly different in either group. And so the other thing to think about is our sort of standard paradigm right now of cisplatin radiation. How does that exert its effect? And so this comes from the late follow-up of RTOG 9111. Basically shows that adding cisplatin to radiation works by improving local regional control, so the hazard ratio of 0.59, p-value is significant. In terms of distant metastases, the p-value is 0.08, so maybe there's a modest trend, but really all of our therapies, whether they be surgery, radiation, or the systemic therapy we add to radiation, are really working through a local regional mechanism. And so I think that's important to keep in mind. So the other thing to think about when we're looking for, early clinical trial endpoints is, can we get the data earlier? And so in this case, this comes from the meta-analysis data that's been cited a few times today. The vast majority of local regional occurrences happen early. So within the first 2 years, 92 to 93% of the time. So that makes that a very useful time point, as opposed to waiting for 5 years. In 2 years, you can start to get what is probably a very valuable signal. And so this come from Soren Benson's group. This was pre-chemo radiation studies, so mostly radiation alone or radiation plus hypoxic radiosensitizer, but it showed there's basically a linear relationship between local regional control and overall survival. So a 10% improvement in 2-year local regional control led to a 6.7% improvement in 5-year overall survival, again, suggesting its potential as a surrogate endpoint. So, a lot of us that have taken care of these head and neck patients realize that local regional control matters, not just as a predictor of survival, but also if you've seen a patient that dies of untreated or uncontrolled local regional disease, it's often a very, very difficult way to go. And so there's unfortunately a dearth of data looking at patient-reported outcomes in this setting. This was the only study I could really find, and it's from 20 years ago. But basically, it looked at patients in 3 disease states. So prior to any treatments, in the disease-free state after treatment, or patients with recurrent disease that were being considered for either salvage surgery or palliative chemotherapy. And they were given 2 EORTC studies, the QLQ-C30 and the HN35. And so what you find is pretty much on all domains, you see improvements in in quality of life that are statistically significant. So in these, higher scores are worse. So you see the newly diagnosed score. Let's look at swallowing, because that was the number 3 on the patient sort of importance list. 15 prior to treatment, 15 for the disease-free patients, but it jumps up to 32 in patients who have recurrent disease. And so we saw improvements on everything other than teeth and coughing, suggesting that quality of life is linked to recurrence. Similar things we're seeing on the QLQ-C30. Here, for the functioning scores, higher is better. So you see lower scores generally in the recurrent setting. And so not quite as many that are statistically significant, but quite a few. Again, this didn't look at the minimally clinically important difference, which we may hear about later in the pro section. So, and yet there are some hesitations about using local regional control as an endpoint. Again, this was the meta-analysis data that's been showed a few times. It's 104 trials, 22,000 patients, and really trying to figure out what works better, local regional control or event-free survival as a predictor for OS. And so prior to the results, they had said that 0.75 was considered a strong correlation between OS and the surrogate endpoint. And so in this case, for local regional control in either radiation alone studies or chemoradiation studies, it was 0.76, which suggests that it is a strong correlation. The only issue is event-free survival was much stronger at 0.86. And so it makes you wonder if event-free survival may actually be better. The other things to note are on the trial, as opposed to individual patient data, the scores were a little bit lower for local regional control. So I think it's worth thinking about what are the ways in which local regional control and overall survival could be decoupled. And so, current drugs that we have right now, Cetux, Carbo, and cisplatin, don't really have substantial effects on distant metastatic disease, but that's not to say that our newer agents won't. And we may not realize that with the new agent until you're at the phase 3 study. And so by choosing local regional control endpoint, you sort of may miss the fact that it actually helps with distant metastatic disease, and event-free survival might capture that, whereas local regional control may not. The other thing is salvage surgery. So in the combined analysis of 0129 and 0522 showed about a quarter of patients were eligible for salvage surgery. And those that did had improved survival. We've also heard from a couple of patients today about sort of immunotherapy in the metastatic setting, and it can lead to prolonged survival in a certain amount of patients as well. And so that would, again, decouple potentially the local regional control and survival as well. And then lastly, we have a host of adjuvant therapy trials, and so it's going to be important to ensure that they don't just delay recurrences past the 2-year local regional control mark, they actually completely prevent or eradicate them. So it's another thing to keep in mind. And so then the question comes up of a co-primary endpoint design. And so you could have a trial that looks at local regional control and also shows a benefit in terms of quality of life. And I think that would be meaningful. The issue, though, is there's some challenges with that. So there is this issue with multiplicity. And so you'd have to share the power between the two endpoints. So you may not have the full 0.05 to show a local regional control benefit. You may only have 0.04 or 0.025 or something like that. So you're making your job slightly harder. So that's one issue. The other issue is your ability to show quality of life improvement may depend on the population of patients you're dealing with. So in RTOG 1016, the local regional recurrence difference was 10% versus 17%. So is that 7% difference really going to be able to come out across the group of patients in terms of quality of life? I would surmise that it wouldn't be able to. Conversely, in the Debio study, the 18-month local regional recurrence rate was 46% versus 67%. So there may be enough recurrent patients there that you would notice a difference. I will say that I think, local regional control is still an excellent endpoint, but maybe for sort of some of the newer, more radiation-focused technical questions. We have the AVOID study, which looked at avoiding radiation to the primary site after TORS, the infield study, which looked at decreasing the volume of nodal irradiation and the dose, and also the MR adapter study, which is looking at weekly adaptation for HPV-positive patients. And all of those are using sort of modified local regional control endpoints. And I think it makes complete sense to use in each of those studies. So in conclusion, local regional control is a strong surrogate for overall survival. Recurrent head and neck cancer is associated with worsened quality of life. And local regional control continues to have value as a clinical trial endpoint, but there are some challenges that exist with its use. Event-free survival appears to be a stronger predictor for OS, and it's likely a better early clinical trial endpoint when we're looking at new agents to add to radiation or assist radiation backbone. Thank you.
Thank you. That was extremely focused and took into account, I think, a lot of the things people have been thinking about. We are now going to move into a panel discussion. And this is going to include Dr. Hussain, and then as well, Dr. Quinn Lee, who's the group chair for NRG, Joseph Califano, who leads the head and neck program at the University of California, San Diego, Ezra Cohen, who's already been introduced as the section chief at UCSD, and Pallavi Mishra Kalyani, who's the lead mathematical statistician at the FDA. And so I think many of the points that came out in the event-free survival discussion may also come out here. But I guess I'm going to start with a question for the group about whether all local regional failures are created equal. So does it matter if it's nodal or primary? Does it matter if it's HPV positive or HPV negative? Does it matter if it can be approached with a transoral surgical approach? Maybe Zen, I'll ask you to start, and then we'll just kind of go around the group.
Yeah, so I mean, they're certainly not. It's, I guess, hard to define ahead of time and to really put them in baskets. But you have the patients that need trachs or need G tubes as a result of local regional recurrence, which is a problem. You have the patients whose disease is eroding through the skin and unresectable. And those are, maybe that's the group of patients that's the most problematic, or maybe the nasopharynx where they pick off cranial nerves. But if you had a small nodal recurrence in the neck that's eligible for a neck dissection, I think that's a little bit of a different problem. If you have a small primary base of tongue that's eligible for TORS, doesn't necessarily need a jaw split. That also may be more favorable, but those are probably more rare, or at least the primary ones that have small salvages may be more rare.
Does anybody want to?
Yeah.
Take that on?
Yeah, I'll just say I thought Zane did a great job. Thanks, Zane, for such a great presentation. In particular, not all sites are created equal, right? We use laryngectomy-free survival as a key defining endpoint for our choice of therapy. So I think our challenge for our FDA colleagues is that we can use local regional control, but we may even be very site-specific and context-specific in the way we evaluate these trials. So I think that really means we can't really have an absolute answer whether local regional control is an appropriate primary endpoint or secondary endpoint in a trial till we understand the question and the site and the disease question being asked. Just as another aside, we are talking about patient-reported outcomes, but I always try to keep in mind that PROs are actually notoriously difficult to power and difficult and have wide confidence intervals. And one thing we suffer from, and my plea is that we look to try to get objective functional outcomes built into our trials, because PROs are going to be super challenging to combine, as Zane pointed out, with any endpoint, be it overall survival or local regional control. So Barbara, of course, not all local regional control endpoints are created equal. In fact, they're incredibly diverse and more challenging in some ways than event-free survival.
Ezra?
Yeah, I'm not sure I have too much to add. Honestly, I think, and that was a terrific talk and coverage of the available data, the paucity of available data. Zane, you did a great job. Again, I would argue that there is a benefit to controlling the disease local regionally, even for the sake of just avoiding that surgical intervention that would be required for recurrence, or in some cases, I suppose, the reirradiation. So even a small recurrence, I think from a patient's perspective, is a big deal. They may survive that. It may be easily resectable with very little morbidity, but I think for the patient, it represents a a dramatic event in their life. So there is some value there that may be hard to capture, even with PRO. That may be hard to capture.
Yeah, Quinn, I don't know if you want to take that on, but what would be the balance of an extra year of immunotherapy and the possibility of being hospitalized from an IO-related toxicity or something like that, versus the need for salvage, and how is there a best instrument with which we could capture that?
Yes, I'm not sure if I have an answer to your question, but I do, I think Zain has done a tremendous job in teasing things out in his presentation. And essentially, I think what we have is we have patients with local recurrence who have, it does correlate with their quality of life. And then the question, if you break it down to different category, are these relapses salvageable and affect their survival, right? So you have the surgical salvageable tumor that can affect their survival, period. And then there's those that are salvageable. Then you break down to category, does it worsen their quality of life or improve their quality of life, right? Because the treatment that's on top of that. And then obviously the one are not salvageable, then what type of salvage therapy can be done and affect their quality of life. So I think that there's definitely a much tougher bucket to address for endpoint. And I kind of agree with Zain is that if we are local regional control is important for local regional therapy. If we are looking at drug that we think that affect local regional therapy, so we're now looking screening stuff for radiosensitized, specific pathway, the radiosensitized tumor, right? And that may be, or maybe when we're looking at radioprotector, that we don't want to be protecting the local tumor that we are looking at radiation. So those kind of the important surrogate endpoint. But if we have if we think that the drug not just radiosensitize the tumor, but can affect the systemic thing, then we definitely need to go to event-free survival as an endpoint. Even quality of life is tough also with what Joe has mentioned. Even we have to break out in where the tumor site is. Quality of life may be very different from patient with a larynx cancer to start out with, and hypopharynx cancer to start out with, than a patient with a tonsil cancer that may not feel their tumor to come in to see us. And so we need to also figure out how to bucket the quality of life based on the location of the tumor to sort out some of these answers. And we collect a lot of quality of life and energy in RTOG trial. We still have not gotten anywhere as far as.
And Dr. Mishra Kalyani, do you have a?
Sure, I can't really comment, I think, on the various parts of local regional control because I'm not a clinician. But what I can say is that, composite endpoints that consist of various different types of events can be very messy sometimes, particularly if those events, as it seems you all are mentioning, are kind of hierarchical in how they may affect a patient. Certainly our classic composite endpoint in oncology is progression-free survival. We look at both progression and death. Generally, we have a lot more progressions than we have death in a study. But the point is that they're both pretty negative outcomes. Certainly death is worse, but we know that having to move on to the next therapy is really what we're looking at, or potentially looking at there. In this case, if you're looking at a lot of different types of outcomes that could occur after the event, so perhaps for the events that occur that are maybe not as serious, or maybe just require some minimal salvage therapy, or require some slight changes but are enough to qualify as an event, that would be very different from something that would end this therapy and you would need to start a different course of treatment or therapy. And so trying to make sense or interpret data from a very heterogeneous outcome-based composite endpoint, I think would be really, really difficult. And I think that's what has been alluded to by some of the prior panelists who said that, we might look at a specific type of event-free survival and look at for the local regional disease itself, which I think makes sense. But then obviously those endpoints are rare and in a single disease setting, which may make them somewhat difficult to maybe validate and interpret, because perhaps they haven't been applied in many different trials or disease or settings other than the one that you might be interested in.
Great, thank you. Another question I wanted to throw out was, do people think that local regional control might have more value as an endpoint in the HPV negative population, where salvage is more difficult and local regional recurrences can grow very quickly? I think we're more used to seeing airway and bleeding problems in that population, and maybe we're more concerned about how the beginning of their course on IO might go.
Yeah, Barbara, I was going to actually make that comment as well, that I think this more and more applies to the HPV negative population, and whereas we often achieve excellent local regional control in the HPV positives, and their site of failure is predominantly distant, although obviously we can all think of patients who failed local regionally. But I think you're quite right, and it may be that we focus local regional control as an endpoint in those patients with HPV negative disease, especially either large tumors or lymph node burden.
Mm-hmm. Thank you. I see some hands up. Lauren, Mel, did you?
Yeah, I don't know about that. So rarely we have interventions where we don't also hypothesize that it's helping with distant metastatic disease. Also, by helping ensure local regional control, you can, at least theoretically, prevent some of the distant metastatic disease from starting in the first place. So what the advantages of withholding that endpoint from your definition in the primary endpoint, I'm not sure the advantage. And I think it's very timely then to talk about the Bonner study and what some of the pitfalls in that analysis, because number one, they did use a quote local regional control endpoint, but it was really local regional failure free survival. And they never actually showed in that initial publication any specific effect of the drug against cancer, which you might think doesn't matter in a randomized trial, but there are myriad reasons why you could have an imbalance in arms driven by non-specific events. So requiring for new indications, direct evidence in that study of an effect on a cancer endpoint, I think should be a critical component of evaluating these new therapies. But I don't see, going back to your original question, on the HPV negative case, I don't see testing interventions that I don't think are going to help with distant metastatic disease. So I don't see where that endpoint has a specific advantage.
Okay. I think Nabil, your hand was up next.
Yeah, I'm glad this is coming from a radiation oncologist as far as the optimism. I think Zaid did a great job, putting the question on. And I couldn't help myself when he was talking about the previous 9111 and the older studies to think, my God, if all of these patients, if they went on today's treatments or the immunotherapy may be the biggest equalizer. So I think I do agree with the notion that we should, and I think we said that before, we should really be granular in our assessment of what endpoints to use depending on the patient population. I agree completely that HPV negative is a different disease. It's still, despite the immunotherapy availability to patients, I think local regional control does seem more reasonable in this disease than in HPV positive. Two big examples. Of course, we don't know what the phase 3 DBO trial will show, but certainly, local regional control was different significantly in the early signal of the DBO trial. Contrast that to 1016, where basically, if you had relied on local regional control as a surrogate endpoint for 1016, you would have not gotten the answer you want. And, we had to wait unfortunately, a long time for overall survival to mature for these patients. And so I do think there's a place for local regional control in some selected patients, probably HPV negative disease.
David Pfister, who is on mute.
There we go. So, some of the comments, and this is actually relevant both to this and the prior panel that have been made, is I think this sort of undercurrent that maybe the study population does matter, and that it potentially, I think this local regional control difference is one example. And I guess that, and going back to the beginning where, if it didn't take so long, that people would say, well, gee, overall survival would be kind of really what we'd like to focus on, but we're looking at other reasons to look at surrogate endpoints. And I think what also factors in that, I think, is a commitment to a randomized paradigm to answer these questions. And so the question that I just threw out there and is, one of my early mentors used to say that you really didn't need a randomized trial to show that penicillin worked. And that while we're focusing on the endpoints we're going to look at, maybe we should spend as equal time to the patient selection criteria that allows us to define questions that we could basically use a more efficient design to answer in the first place. Now, I'll admit that this is much easier in, let's say, the recurrent metastatic setting, or something like anaplastic thyroid cancer. But, I think that, when you actually look at a lot of standard of care, it heavily evolves from actually non-randomized data. And the question is whether with maybe, in a molecular medicine era, that if you have like a adenoid cystic cancer and you've got a Notch mutation, that's bad news, okay? And, do you need the same type of design to show that there's an effective therapy in that setting as you do, with a less selected population? So I guess I just throw out, how do we want to define the baseline for these folks? Because, and are there going to be subgroups where you could actually use a more efficient design than be committed to a randomized trial?
Yeah, no, and I think that we can all think of many examples where useful drugs have been jettisoned because of a unwillingness or a failure to use molecular selection. And if you come back for the 2020 meeting, I think that's going to be a big part of the 2022 meeting. It's going to be a big part of the discussion in part 2 of this. I think one other person still had their hand up, although we are meant to be finishing at 4. Joe Califano, did you want to give a final?
No, I thought I was going to say what Nabil said, so I'm not going to waste everybody's time by saying it again.
Okay. Well, thank you all for bringing your wisdom and thoughts to this. I think this was a great discussion. And I'm now going to pass it over to Dr. Gautam Mehta, who's going to moderate the session on patient-reported outcomes.
Thank you so much. This patient-reported outcome topic has come up several times in the earlier discussions. And are clearly so important in head and neck cancers. So we really consider it essential to complement these discussions with an overview of patient-reported outcomes here. To lead off this session, I'm delighted to introduce Dr. Kate Hutchison. Dr. Hutchison is a professor in the Department of Head and Neck Surgery and the section chief of Speech and Language Pathology and Audiology at MD Anderson Cancer Center. She has made considerable contributions in head and neck research, particularly in the areas of dysphagia and swallowing function outcomes for patients with these cancers. And I'll hand it over to Dr. Hutchison, if you can share your screen. Let me see.
All right, I'm now unmuted. Are you seeing my full screen?
We see it in the PowerPoint window. So with the header.
Okay, let me just stop for a sec. Not sure why it's acting funny.
That's perfect.
Perfect. All right, so you're seeing the full screens here. It's been a really great session so far, and nice to hear PROs sort of integrated throughout the day. These are my disclosures, and let's just get into it. So PROs, as we know, are an unfiltered outcome by definition. So they're defined as a report of a status of a patient's health condition that comes directly from the patient without interpretation of that response by a clinician or anyone else. And we've already heard some comment on patient priorities. So PROs, as we know, are intended to focus on outcomes that matter to patients. There have been data examining these priorities for decades now that all sort of consistently show that the number one priority of a newly diagnosed patient with previously untreated head and neck squamous carcinoma is going to be cure of their cancer. But that there are then relative rankings of the functional priorities of patients. So if we look at the body of literature, these data that are now 20 years old from Marcellus still hold true, and that the top functional priority tends to come out as swallowing preservation, but then shortly behind that, typically preservation of the natural speaking voice and preservation of appearance, which is important when we think about things like trach, laryngectomy, stoma, et cetera. So the origin of PROs as endpoints in head and neck squamous carcinoma clinical trials, which we're talking about today, I would argue has been to assess these functional outcomes specifically. And sort of the genesis of this comes from a lot of data over the years that suggests that the way we as clinicians grade these functional outcomes don't always match the way that patients perceive these outcomes. And that's whether we measure them with, conventional toxicity grading using CAE or these so-called objective measures such as a modified barium swallow study or something like that. But I think that it's really critical when we think about PROs to broaden our lens and remind ourselves that there are tons of PROs that have been developed to measure many more things than functional outcomes. And so this is just an example of all the domains that are out there for PRO measurement. So health utilities, symptoms can be measured both in their severity as well as their burden. So the bother or the interference that a symptom causes an individual. And we heard a lot about how that interference based on symptoms sort of evolves from early to long-term survivorship when we heard from patients earlier today. Functional outcomes can even be split beyond just physical functional outcomes, which is arguably what we measure in most of our trials. Things like how well do you swallow, what's your neck function, versus role function, which is going to get a bit more at that psychosocial domain. And then quality of life, which can be broken down into disease-specific quality of life or overall health-related quality of life. There are impact and interference measures and even, quality metrics, such as satisfaction or adherence to health regimens. So if we distill those broad domains down, there are 5 core domains that I think we'll hear a bit more about in the next slide presentation that were recently described in this draft guidance that was published for comment in June of this year by the FDA as the core domains that are recommended for measurement in patient-reported outcomes in cancer clinical trials. And so these 5 domains include this disease-related symptoms, the symptomatic AEs, the overall side effect impact, and then function specifically broken into physical function and role function. All right, so one of the first steps in integrating PROs as an endpoint is deciding which one. And I think that this is arguably a very challenging step in the field. A nice resource that's been developed, this was published in 2015 as an outcomes toolbox where a subcommittee of the NCI Clinical Trials Coordinating Center, specifically the Head and Neck Steering Committee's Task Force for Previously Untreated locally advanced disease, came together and published this monograph where they recommended a variety of instruments, PRO as well as clinical metrics, that were put forward to measure the patient-centered outcomes in head and neck cancer research. So these were recommendations based on the published validity, but also the feasibility and what was perceived as the sort of clinical acceptance of these outcome measures. I'll highlight that there are over 25 patient-reported outcomes that are listed in this publication, and there are 6 disease-specific PROs for head and neck cancer, and 5 physical function specific PROs, so things like swallow, neck function, voice and speech, et cetera. So if we attempt to map that published outcomes toolbox to these 5 domains of PROs that FDA has recently released as priorities, we can see representation of all the domains in that existing outcomes toolbox, which may give us at least a starting point for instrument selection. So for instance, there are 2 PROs here that are measuring disease-related symptoms. There are 27 CTCAE items that have been highlighted for measurement of symptomatic adverse events. There are 3 PROs that have at least domains within the instrument that measure the overall side effect impact. There are 7 physical function PROs. Arguably, a number of these are function specific, whereas EORTC and FACT-HNN would look at functional status across multiple domains. And then there are 2 PROs that include role function. And if we look beyond guidance that's out there to help us identify which PROs we might use in a trial, there's also guidance that I would consider to be the sort of how to implement PROs appropriately into a clinical trial, both from design to implementation to analysis and reporting. And so there are 3 relevant publications I've included here. The CONSORT and the SPIRIT Equator checklist both have PRO extenders. So the 2013 publication for CONSORT gave us 5 items that are recommended for reporting of PROs from a clinical trial. The 2018 SPIRIT extension gave us 17-item checklist for things to consider when implementing PROs in the protocol development phase. And then more recently, and arguably a much longer sort of document, the CISAQOL Consortium in 2020 gave 32 recommendations that are specific to the use of PROs in clinical trials for cancer. And these are actually a lot more focused on the analysis, and I think quite relevant to the discussion of endpoint selection using PROs. So I thought I'd wrap up the last 5 minutes or so by just looking at recent examples of published PRO use in head and neck trials for squamous carcinoma. And the first example I pulled forward were the PRO results from ECOG 3311, which we've heard about today. As we all know, phase 2, RCT examining de-escalated adjuvant therapy. So PROs in 3311 were a secondary endpoint. There was a single hypothesis-driven analysis that we see depicted on this left-hand panel here. And this was looking at the change in the FACT-HN as a measure of disease-specific quality of life at 6 months relative to baseline. So a priori, the plan was to compare the percentage of patients who had stable or improved quality of life according to this measure, pooling the 2 de-escalated arms relative to the CRT arm. And the idea was that this would be potentially like a representative of what would be a phase 3 comparison. And they did in fact find statistically significant difference as hypothesized. So 56% of patients in the de-escalated adjuvant therapy arms had stable and or improved quality of life at 6 months. This was relative to baseline, and that was compared to 38% in arm D. They also included in the primary publication of the trial descriptive results of the MDADI, which is a swallow-specific PRO that most are familiar with. And if you look at the longitudinal trajectory and you sort of focus on the 1 year and the 2 year time point where, you know, the adjuvant therapy has already been delivered or not, you see that the trajectories really only separate for the arm A, the low risk arm that had no adjuvant therapy, compared to all the adjuvant therapy arms that are relatively overlapping in their means. And this difference does, if we, you know, hover this bar here, I've tried to draw on the plot of about 10 points, which is universally kind of considered minimal clinical importance for the MDADI. We can see that this does appear to be a clinically meaningful difference. Let's look next at the use of PROs in HN002, again, recently published by Dr. Yam and JCO. And in this trial, PROs were actually used as a co-primary endpoint. So co-primary endpoint of 2 year PFS of more than 85%, as well as a mean composite MDADI score of greater than 60. And we can see at the 1 year time point that both of the treatment arms far exceeded that co-primary endpoint of quality of life, with their mean scores hovering between about 82 and 85. The protocol obviously also included PRO analysis as a secondary endpoint and gave this sort of hierarchical tiebreaker scenario where if PFS was met, that the phase 3 arm selection would then be based on both a between arm comparison of the change in the MDADI scores at 12 months relative to baseline. And we see this as a pretty recurring theme on hypotheses using the delta rather than the absolute. We can see that was not detected in the analysis. There was no significant difference in change between arms. They also would have required in this step 2 the 5-point within group MDADI change as a threshold. And what I mean by that is no more than a 5-point drop in MDADI scores in either arm that proceeded forward. And we can see that if we'd gotten to this step, that neither of the arms would have actually met that. And I think it kind of it speaks to the importance of getting the right threshold, because arguably the step 1 had a very low bar to clear. A mean MDADI score of 60 is actually pretty terrible function in a group level analysis, whereas within group change score of 5 points is actually a pretty high bar to clear. So just getting to the nuance that we've heard about using PROs in these trials. The final example I'll show of PROs in a published trial are the PRO results from 1016, which we've also heard about as we all know, a phase 3 comparison of concurrent cisplatin versus cetuximab. There were 3 PRO instruments that were included in the trial. So these included the EORTC, both the C30 and the head and neck 35, EQ5D, as well as PRO CTCAE. And the only PRO results that have been published so far are this single table that was a supplementary table to the primary result, focusing on the swallowing domain. They identified a single statistically significant difference between the arms at 1 year. And this actually was counter to expectations. So for the swallow domain here, higher scores are worse. And so you actually saw more or worse change scores in the cetuximab arm compared to the cisplatin arm, which was obviously the unexpected direction of difference. I actually find the longitudinal data here at the group level almost more important than the comparisons, because it gives us the picture of how the patients were doing and what we consider to be this sort of priority functional outcome. So I'm going to walk you through just looking at the interpretation of the mean scores over time for both groups, because they're actually fairly similar in their range. So at pre-treatment, we could see that on average, patients on this trial in either arm were reporting swallowing problems that fell in this sort of not a lot to a little range. At the end of treatment, that was the mean scores represented about quite a bit amount of swallowing difficulty. By 3 to 6 months, the scores on average fell in the range of a little swallowing problem. And then on average, by 1 year, scores were back to that baseline range of not a lot to a little swallowing problem. So perhaps, and as we've all heard, a very important early endpoint, but perhaps at 1 year, we're seeing the sort of early recovery before the late effects where there's not going to be quite as much salience of this endpoint relative to others. I'll wrap it up with this slide. This is a really relevant systematic review recently published, patient-reported outcomes in clinical trials leading to cancer immunotherapy drug approvals from 2011 to 2018. There were 2 head and neck trials among 44 trials that were included in this review. And the authors summarized that among these 44 trials, 48% included PROs in their publications. These were always used as secondary or exploratory outcomes. Hypothesis-driven analyses were only used about 19% of the time. And secondary manuscripts of the PROs were only published about 30% of the time in a median of 19 months after the primary trial. The EQ5D was the most common instrument in 81% of trials, and a 40% also used disease-specific PROs. So just in conclusion, the PRO reports in head and neck squamous carcinoma currently are primarily focusing on physical function and particularly swallowing function. This is linking to what we've seen in patient priority data in the published literature. But we see that the FDA prioritizes more domains than physical function. And I think that one place that we can work with our patient stakeholders to get there and figure out how to integrate a more holistic PRO approach without too much burden would be patient-engaged research. There is a huge framework for this that already exists in the field, and I'd point us to some resources here, including the PCORI, as well as this recent commentary that was published in JNCI on a framework for patient-engaged research that was published specifically out of SWOG. So thank you for your time and looking forward to the panel discussion.
Thanks, Dr. Hutchison. So we'll now hear about the FDA perspective on PRO from Dr. Vishal Bhatnagar. Dr. Bhatnagar is a medical oncologist at FDA and is the Associate Director for Patient-Reported Outcomes in FDA's Oncology Center of Excellence. He helped author the guidance that Dr. Hutchison referred to. So I'll hand it over to you.
Thank you so much. I really appreciate the opportunity to speak at this workshop. My name is Vishal Bhatnagar. I'm a medical oncologist with a clinical focus in multiple myeloma. I'm also the Associate Director for Patient Outcomes in the Oncology Center of Excellence. And as I said, I really appreciate the opportunity to talk about PROs here. So far, the discussion has been really robust, and I think that there's a great opportunity to include PROs in head and neck cancer trials and registrational pathways. I'd also like to thank Dr. Hutchison for her presentation, which very clearly outlines the state of PROs in head and neck cancer trials, and to the other panelists who have mentioned PROs along the way. So with that, I have no disclosures. And this is a brief outline of my presentation. First, I'll describe common pitfalls and sort of more of the status quo of what FDA sees when it comes to PRO data that's submitted to the agency. And then I'll describe some of the regulatory challenges that we have faced over the past few years in regards to PRO data, and specifically how we review this type of data. And then I hope that the take-home message from my presentation is around that recently released draft guidance that was recently mentioned on core patient-reported outcomes. And then specifically, I'd like to highlight not just the instrument selection, but also the optimal assessment frequency of PROs. And then lastly, I'll describe Project Patient Voice, which is a new innovative way to communicate PRO data, which we hope better informs patients and providers. So essentially talk about the way that we can disseminate this data outside of the label. Before I get into the details about patient-reported assessment of symptoms and function in head and neck cancer trials, I'll just zoom out to sort of the 10,000-foot view of what we do at FDA in regards to what patient-focused drug development actually is. So this refers to the inclusion of the patient perspective across the drug development continuum. And that includes patient symptoms and function, which can and ought to be measured early, but as well as late trials. Patient symptoms and function can be very assessed in early phase studies and can help select dose. And I think that the applicability here that we've discussed in today's discussion is about late-stage trials and incorporation in earlier clinical endpoints besides OS. But I just wanted to reframe the discussion a little bit and say that PROs can and should be measured even early on in drug development. We have a few challenges when it comes to handling patient-reported outcomes and patient experience data from a regulatory perspective. On one hand, recent legislation, the 21st Century Cures Act, does encourage FDA to review and communicate patient experience data that's collected in trials that support regulatory approval. This is really valuable information, and everyone would agree, I think, that this is important to include the patient voice in our reviews and in our approvals. But in almost all product applications, the PRO data that's submitted is quite heterogeneous. It can be very differential in terms of the way it's presented. The claims that are being provided by the sponsor can widely vary. And even if this data is well presented and meaningful and impactful, we found that the product label may not be the best place to communicate this information. And particularly the audience of this information shouldn't just be healthcare practitioners, but should include patients and caregivers. So we thought about ways of communicating this data, particularly understanding the limitations of the label, which are lack of color in terms of figures and limited space. As we've seen, PRO visualizations require a lot of space and can require line charts, bar charts, pie charts, etc. The figure you'll see here is what we actually see quite a bit, or used to see it quite a bit from industry sponsors about traditional randomized trials. So this is overlapping curves with very wide confidence intervals on something like a global health score or a physical function domain or a multi-symptom or a multi-item symptom domain. And then there will be a broad claim that there was no difference between arms or no detriment was observed. I think from our standpoint, we need to move forward from this. And you'll also see that there's a very wide assessment frequency. So every 2 months here, frequently we see every 3 month assessment frequency of PROs. And these isolated snapshots every few months may not accurately reflect the symptoms and function patients are having on a day-to-day basis, but more reflective of the actual patient experience and when those symptoms would be most likely or functional deficits would be most likely to occur. Our goal in the OCE is to take a step forward away from this, and I'll describe what the preferred approach is. But in short, just these overlapping global health or broad quality of life scores is not what we are looking for, particularly if we're looking specifically at disease symptoms or if we're looking at relative tolerability. And if depending on what is important for the trial, whether it's an improvement in tolerability of treatment or an improvement in disease symptoms, that needs to be very clearly pre-specified and handled as an endpoint prior to trial initiation. So once we then receive data, our FDA reviewers, this is sort of the review strategy from the FDA's perspective. So it's first important to consider what instrument was used. And I think Dr. Hutchinson went very clearly through the different types of instruments that can be used. And what we do on our side is try and match whether the concepts that are important to measure or that were intended to measure were measured, in fact, by the instrument selected. And is this appropriate for the disease and treatment that is being studied? Next, it's important to consider what the purpose of PRO in the trial. And as I said, it could be whether it's tolerability or specifically a type of disease symptom, or in some cases, it can be broad health-related quality of life, or as many HTAs would need that in order to make their determinations. But from our standpoint, we really do, as Dr. Hutchinson mentioned, focus on the 5 core outcomes that we've outlined in the draft guidance. Once we take a look at essentially the instrument that was selected and whether the endpoints were in the statistical hierarchy, then we think about what confounders could limit interpretability of the results. And one of those main things that we also look at is the amount of missing data. Unfortunately, as was discussed earlier in the day, there is quite a bit of missing data that plagues PRO data. But that being said, over the last few years, we've noted that the quality of data and the completion rate, i.e. when patients are provided a assessment that they actually fill it out within a certain time range of receiving it, that proportion has gone up quite a bit. And I'll mention later on, part of the reason why is electronic assessment of PRO as opposed to in-clinic paper and pencil. So data missingness is vastly improved. However, we still want to make sure that data is not missing, and even worse, that data is not missing in an asymmetric fashion. For example, that in an open label trial, that patients in the experimental arm provide responses at a higher rate than those in the control arm. Next, as I mentioned, the assessment timing and frequency are really important, and assessments need to be conducted at the most important times of symptom or function detriments or improvements. Finally, once we've analyzed the data, we need to make sure that a conclusion can be made on these results and that that this data is meaningful for patients, caregivers, and practitioners, and that there are clear implications for them to view this data. And then lastly, and I won't spend too much time on this, how can we share this data with the public? So I'll briefly just go over the core concepts. And again, Dr. Hutchinson mentioned the core outcomes. What I'll first do is show you the more traditional endpoints, the clinician-reported and biomarker data that we receive in almost all, pretty much all clinical trials that are submitted to the agency. And this includes measures like overall survival, clinician-reported safety, and then health utilization data like hospitalization. But the type of data that we're talking about today is patient-generated data. And we've designed a core outcome set to generate some sort of consistency in the field. And this includes disease symptoms, symptomatic adverse events, overall side effect bother, and physical and role function. The point that I want to make here is that these are not the only measures that should be collected, but this is a bare minimum of areas or domains to collect. And although we've found that these are 5 important domains, there are obviously other things that can and should be measured depending on the trial context and treatment that is being studied. And furthermore, I'd like to also just say that there are efficient ways to collect these 5 domains. And we found in most trial settings that these 5 domains can be covered in less than 40 questions or 50 questions, which would take a patient less than 5 minutes or so to fill out in any given encounter. So again, the main thing that I wanted to impress was that there is an importance to the when to measure these domains, and the assessment frequency, and this represents sort of the biggest change over the last few years, is a more frequent collection of PROs as opposed to every 2 or 3 months. So what you'll see is on the left, the core outcomes, and this may look overwhelming, but it basically boils down to measuring certain domains more frequently as opposed to others. As you'll see at the outset of the trial, when patients, for example, may be more likely to have changes because of the treatment or side effects, you'll see that there is a high frequency of symptomatic AE collection, physical function collection, and overall side effect bother. And then as you move through the trial, there is a spacing out of these domain collections to every month and then every 3 months. And this can be very much tailored depending on the trial that and the expected duration of trial at hand. So in a early stage prostate cancer trial, this assessment frequency will look very different than in a metastatic head and neck cancer trial. What I'll also say here is that there needs to be very frequent and specific measurement of certain symptoms. So, for example, in a head and neck trial, swallowing function or dry mouth needs to be collected at more frequent time points when those detriments are likely to occur. So these core concepts and example frequency, as well as other very important regulatory considerations, are all included in the recently released Oncology Center of Excellence draft guidance. So this guidance was very long in the making, many years in the making, and we appreciate the feedback that we've received about this draft guidance, and we're continuing to present it at workshops such as this in order to get more feedback as well. So, and we've received quite a bit of feedback from patients and patient advocacy groups about this guidance as well, and we're incorporating that as we finalize this guidance. And I will wrap things up by talking a little bit about the Project Patient Voice, which I mentioned earlier. And this is really a tool that we've developed to disseminate this important type of data. So let's say the patient-reported outcomes data was well collected, meaningful, interpretable, high frequency, good completion rate. Then what? So we want this information to be accessible to patients and healthcare providers at the time that they need it the most. Which is in the clinic, right when treatment's beginning, or perhaps when they're encountering a significant adverse event that may be challenging. They need to know sort of what did the trial look like, what is the experience of other patients who have gone through this treatment or experienced this disease. And so for that reason, the FDA Oncology Center of Excellence created Project Patient Voice. In June of 2020, we launched this publicly available pilot website to disseminate well-collected, rigorously collected PRO. And I just want to also make clear that this does not replace the label. This does not replace the safety data that's included in the label. This serves as a complementary source of tolerability information. As you'll see, we included week-to-week longitudinal data for a multitude of symptoms in this pilot case, and the pilot case is in lung cancer. I will point to the link at the bottom right, and again, I don't want to take up too much time talking about Project Patient Voice because I think that folks want to discuss the more applicable disease symptom data that was brought up to this point. But I just wanted to say that this was a tool that we developed and I think will be helpful perhaps in the future when it comes to tolerability here. So where do we go from here? Based on our experience in other areas of oncology, we know that PRO can provide systematic and accurate data on patient symptoms and function if well collected. The data quality has improved quite a bit, as I mentioned, and technology has led to quite a bit of improvement in terms of collection of patient-generated data. We've also used technology to help communicate patient data, patient-reported outcomes data outside of the label, as I just mentioned. And lastly, we're working with academic collaborators on ways to collect and report this tolerability information. So just to wrap things up, assessment of patient-reported outcomes on an infrequent basis and drawing conclusion over a small subset of patients is not enough. It's important that all oncology studies include PROs prospectively and to define those objectives and endpoints very early on. Our recently released draft guidance states that we should focus on key areas that are directly important to the disease and treatment being studied. And these can vary widely between studies. And I think I'm looking forward to having a further discussion in the future about this specifically for head and neck cancer trials. We outline ways in which PRO data should be collected and this data should be analyzed in a way that's meaningful and interpretable to those that need this data the most. And then there are certainly many opportunities to collect this important information using sensors or wearables and then disseminate it using something like Project Patient Voice. Again, I'd like to thank the workshop organizers for the opportunity to present this information. And I think that there's going to be another workshop in early 2022 to go further into this. And then I'd also like to put a plug in for a few things that were mentioned as part of the panel discussion. I think Dr. Califano, you mentioned that sample size and designing clinical trials that include PROs can be quite difficult. And I completely agree with what you said. And it does take a lot of foresight and thought and planning if you do plan to include an alpha-controlled PRO endpoint. So I just wanted to reiterate that. Dr. Hutchinson, you mentioned the use of existing PRO instruments in terms of head and neck cancer trials. And I'll also just add on to that by saying that there is the potential to use item libraries. So not just the specific established PRO instruments, but perhaps use grab certain questions off of the shelf using something like a ProC-TCAE or an EORTC item library, so you can pick and choose specific symptoms that are relevant to head and neck cancer trials. And then the last thing I'll say, and then I'll turn it back over to you, Gautam, is that the EQ-5D, although it does measure concepts about function, the FDA Oncology Center does treat the EQ-5D as a more broad-based, generic health-related quality of life instrument, and we would not generally rely on that for disease symptom or evidence of disease control or local regional control or EFS. So I just wanted to put those three things out there. Again, thank you so much for the opportunity to talk and hear my acknowledgments. And back to you, Gautam. Thank you.
Thank you so much. I know we're just touching the tip of the iceberg here, but since we have limited time, we do have to move on to the next section. So this is going to be moderated by Dr. Aaron Larkins. I'll hand it over to you.
Great, thanks so much, Gautam. And we're going to try to stay on schedule for 4:55 to end this. So our panel discussion will be a bit shorter. I'd like to thank the panelists for participating in this sort of wrap up. And I think what we'd like to start with is have each of you maybe tell us what you feel the key points from this workshop have been, or what you've come out with from listening to the discussion as far as endpoints. So why don't we start with Dr. Pfister?
Well, really appreciate the opportunity to participate. There were a few, hearing kind of like the afternoon in total, I did get a sense that there was a feeling that there is a role for the importance of these endpoints like event-free survival or local regional control. I would say that my sense was that there was greater enthusiasm for event-free survival. I think that another theme I thought was that there's quite there can be heterogeneity in how these are specified, and that there needs to be consistency in specification. I think that there can be population-specific areas of that will impact the utility of the measure. I think, the difference in local regional failure between HPV positive and HPV negative disease was one of the examples that came up. I think that there was sort of an undercurrent of the impact that IO has on this conversation and crossover therapy and so forth. And I think that certainly deserves more attention. I don't think the issues with crossover are new. And so I guess that I sort of feel that it's maybe getting overstated a little bit, but that's just my bias. But there was a clear undercurrent that it deserves more attention. I think, we really didn't talk about things like liquid biopsies, which clearly could affect the equation here in terms of, all this scrutiny that we're thinking about the PET and when to get the PET and so forth, that you could certainly see a perfect world where a blood test kind of simplifies that discussion, but it's never that simple. And I think the last thing, really enjoyed hearing the perspective of the patients. I did get a sense that when it was all said and done, that they were there to sort of tell their story was the highest priority. And I think that it's sort of, and even a site in the head and neck where there's so much about function, and I think it was a great discussion on PROs, that it was, that's important to us, but it was, you remember on that one slide, it was sort of cure, survival were the first two things there. And not to diminish the importance of other things, but it did seem that was very important to patients. That's what I came away with.
That's great, thank you. And the ctDNA issue is a really good point, and something we expect and sort of hope that we'll be seeing incorporated into trials going forward much earlier in development. And that is going to be one of the topics that's discussed a lot more at the second half of the public workshops that we're hoping to do in the first half of next year. So there were a lot of topics here like that, and de-escalation, things that we knew we could not fit into an afternoon workshop given all the time this discussion has taken. So we definitely are looking forward to delving into that a little bit more and seeing how that can be brought into these studies. So next, let's go to Dr. Spencer.
Thank you so much for the invitation. This has been really enlightening, and we've sort of recapped many things that we've talked about in clinical trials over many decades. But it is, I think, a great thing to try to crystallize, or at least for us to all be on the same page about what might be important. And so I think I heard the themes of that today. And these themes are looking at, not only local control, but event-free survival. I think all of those are incredibly important. And it may turn out that we won't be able to find maybe the one thing, and we might have to rely on some of the older indicators that we've used in the past, but add in things such as liquid biopsies, radiographic information. There's this whole sort of realm of radiomics that can at some point be integrated into the things that we are looking at right now. And you could imagine that as patients become more and more engaged, such as those two spectacular patients that presented today, that they will help us push closer to what is indeed important to them. And so the giving of life, or this sustaining of life, I believe is going to always be important to patients. And so we have to keep that front and center. I think there are many studies underway that will help us with some of these toxicities, some that are coming in through ECOG, some that are coming in through NRG. You look at other technologies such as protons, which may change the landscape a little if we're smart about how we use that technology and when we use it. I think it's going to help to mitigate some of the symptoms and the burdens of symptoms that patients have. So it's been an excellent discussion, and I look forward to the next one.
Great. We're so thankful you could join us today. Next, I'll go to Dr. Burtness.
Thank you. Well, very much the same themes. First of all, just so fabulous to be having this conversation with you. Second of all, I too took from the stories that Jeff and Steve told that they had been through a lot, but they were doing great. And in a way, I think that that's probably the to me most compelling argument that overall survival remains, our highest priority endpoint in this disease. I thought that the talk from Bob Ferris about how surgery has changed, how reconstruction has changed, it was another thing that made me, question kind of the old dogma about locoregional control. But I see a disease where there are many molecular and immune targets and very few options for our patients. And so early endpoints, I think, have to be an important priority. And so I guess I kind of walked away thinking event-free survival is probably the best that we have at the moment. And that we need to continue to track its relationship to overall survival moving forward.
Great. Thank you. Dr. Cohen?
Yeah, thanks. Thanks, Erin. And I'm not sure I have much to add to the erudite comments from Barbara, Sharon, and David. I usually don't have much to add to what they say. I am a believer in action items and moving, promptly towards a goal. This was I think a wonderful start to what we all want to achieve, and that is quicker outcomes, appropriate changes in the standard of care based on validated endpoints that will help patients at the end of the day. What I took away from this was almost exactly what Barbara just said. I think event-free survival is that endpoint, and we should work towards that. I think an action item from this first meeting should be to further define not only what that means in the context of head and neck cancer, and it may mean different things for different populations or different trials, but also what we need to solidify that as an early endpoint for approval. So hopefully, we can begin to think about that. All of those other aspects that we didn't get to discuss today are clearly important. They are part of our future, and I look forward to the 2022 meeting to begin to discuss all of those things. And thank you again for the opportunity to be a part of this.
Thank you, Ezra. So I'm going to start with you for the next step. We're going to sort of go in the opposite order and like your opinion, sort of prioritizing the next steps for where we go from here to get EFS where we need to be, where we may need it to be. And also if you have some ideas about how we start to look more at local regional control as well.
Yeah, so sure. So I think the first thing is we need to begin to define what EFS means in the context of locally advanced head and neck cancer. As you heard, there are, I wouldn't say an overwhelming number, but a few parameters that we would pay attention to and choose to include or exclude. I think defining a working group that will come up with a definition and then eventually agreeing on that, I think should be a first step. It would be great to collect modern data from clinical trials that have been completed in the HPV era. The icing on the cake would be to collect data in the immunotherapy era, although those may be a little bit harder to come by, so that we can feel more secure that, in fact, EFS does reflect overall survival, and I think it will. In fact, I think it will be a tighter correlation than the previous meta-analysis. So those to me would be the two major steps to go forward. In terms of local regional control, I think the same things apply. And local regional control, I think for the minority of trials may be the more relevant short-term endpoint. So it's an exercise worth doing. Thank you. I'm done.
Great. Barbara, Dr. Burtness.
I'm not going to repeat all of those comments because they were quite pithy and they got to the point. I guess I will try to build on them with a couple of observations. One is I thought we had a very long discussion early in the afternoon about where does a neck dissection after definitive chemoradiation or definitive whatever drug radiation fit in terms of defining an event. And we heard a lot of different perspectives. I don't think that the data are really there to tell us exactly what to do, but I remain skeptical. I think it's something that's more susceptible to bias, either by the treatment team or by the amount of underlying disease. And I really like the suggestion that we heard from David Pfister that we kind of say the first 16 weeks, 20 weeks, whatever it is, are the package of definitive treatment. And then we take patients who've emerged from that and look at what's their subsequent course. I agree that local regional control can be devastating for people. I'm concerned that the way we use it now, we're lumping really minor events in together with very major events. We're potentially lumping some events that the radiation might have just taken a few more weeks to kill off all the cells into there. And so to me, that is not ready for prime time, even even though it's been used so much over the decades. But I agree that we need to continue to study it, and particularly in HPV negative, it may be very important.
Thank you. Before I go to the next panelist, I just want to mention that we do like to take photos for these when we can. So if all the panelists could stay on, if you're able, we'll try to get a picture right before the preview of part 2 and the workshop. But same question to you, Dr. Spencer. Next steps, you think, where we go from here?
I don't think I have much more to add. I think we have developed the building blocks for, the important things. So I believe the action items that Dr. Cohen addressed is definitely a great place to begin starting.
Thank you. And Dr. Pfister.
So I think just basically to add on what's been previously said, the one opportunity I think that I would, if there is a focus on event-free survival, then I do think there's a priority to sort of use as much existing data as possible to get a better understanding of its of where it works well, where it works better, where it works less well. And I think the opportunity, if I had to throw out like an area that I think I'd be keen to see more information would be, head and neck cancer. It's historically sort of a disease of older individuals. We know from meta-analyses data that the survival differences in people over 70 starts to go down. So that pretty much you're going to have, even for therapy that we think is effective, it's hard to show it based on trial data in people that are older. And so it's almost like that's an opportunity then to better understand, well, what would event-free survival do in the same population where we know there's probably going to be very no or no survival advantage if you're looking at overall survival as an endpoint, likely because of competing causes of mortality. Conversely, I think that in the younger population, which you think more like the HPV positive, what I would kind of throw out is what might we learn from the testis cancer experience using sort of survival and then looking at event-free survival in a population of people that are likely not going to die of other things, and see if there are lessons to be learned there. I think that to follow up on the one comment that Barbara made, I do think that what are clinical criteria that go into deciding whether a patient truly is disease-free so that there's consistency among observers. I come from a background in clinometrics. It's generally viewed as sort of being like, that's soft, but implicit in the fact that PROs figured very prominently in the discussion today that when I started my training, that was that was a soft outcome. Now with scientific methods, there is a way to make it a hard outcome. And I do think that clinical assessment probably can be done in a way that is, between clinical assessment and the, integrated with imaging data that is done in a reproducible way. And then I think the last thing is something I mentioned before, is it always strikes me with trials that, you're kind of in this tension between getting enough patients so that you can accrue in a timely way, but that you have some trade-off with patient heterogeneity to get those numbers. And so I guess the question is that probably you could envision sort of a receiver operating curve where if you're able to better define the population, probably the sample size you need to answer these questions probably goes down because the confidence intervals around your estimates get narrower. And whether there'd be a way that we, particularly with what probably sounds like it's going to be something covered at the next workshop, where we define these populations in such a way that we're able to sort of answer questions with fewer patients and likely sooner, because the confidence intervals around the outcomes are going to be narrower.
Great. Thank you all so much for participating. I also just wanted to say thank you to Dr. Harpreet Singh, who's our division director here in Division of Oncology 2 that manages head and neck cancer. She really pushed us to organize at first a mini symposium and then push this forward to a public workshop so that we can hopefully really advance where head and neck cancer is going, which is our ultimate goal here. All right, with that, I don't know if we should do the photo now, I think, if everyone can come on camera. Hi, Tony, you usually let us know when we're ready to go.
Yes, I think Tony's having audio issues, but if everyone's ready, yes, if everyone's ready, just let me know. All good? All right, if everyone can look in on the camera, 3, 2, 1. All right, perfect. Thank you, everyone.
And now I'm going to turn it back over to PJ for a little preview of the second half of the workshop we're hoping to have next year and closing remarks.
All right. So on behalf of all the FDA organizers, I want to sincerely thank Dr. Cohen, Dr. Burtness, and all of the speakers and panelists for the amazing and stimulating discussions today. We are truly thankful that Mr. Shoup and Mr. Cassidy were able to share about their experiences and perspectives as patients. And it was important to hear about efforts from HNCA and SPONC in supporting patients from both Ms. Hollinger and Ms. Caputo. We had robust discussions about the need to further define and standardize events included in the EFS and LRC definitions and how this may vary for different populations of patients. There seems to be an overall consensus regarding issues with LRC and that its use may only be appropriate for very select situations. There was excitement for EFS as an early clinical endpoint, but work needs to be done in understanding its relationship with overall survival, particularly in the era of immunotherapy, in which there may be more likelihood of decoupling of the two endpoints. Finally, we need to talk about PROs in greater detail, which we hope to address along with other important topics in part 2 of this workshop in 2022, including, as we've already mentioned, the use of ctDNA, a focus on HPV-associated tumors, and the intensification strategies. So thank you again for a really, wonderful afternoon, and we hope to see you all again very soon.